Good morning. My name is Bill Ellis. I'm a professor of urology at the University of Washington, and I'm going to be talking to you about prostate cancer treatments, primarily focusing on surgical treatments for prostate cancer. By means of disclosure, I am a funded clinical trial study investigator for Nanospectra, which is a focal laser ablation technology company. So briefly, we're going to be talking a little bit about active surveillance or just observing low-risk prostate cancer, radical prostatectomy, and focal therapy. And we'll do a few comparisons between radiation and surgery. But Dr. Liao is going to be talking to you later this morning about radiation, so I won't get into radiation in great detail. The current paradigm for prostate cancer is to try and reduce the burden of localized prostate cancer treatment by not overtreating prostate cancer. So we're trying to balance the risk that the cancer poses with the life expectancy of the patient and the potential morbidity of any treatment that we might undertake. Active surveillance is based on the concept that most men with low-risk cancer don't have something that's likely to harm them. Most men will eventually develop some prostate cancer, and most die with the disease, not from prostate cancer. So the goal is to balance cancer risk with the morbidity of treatment. And it's important to understand that active surveillance is not no treatment, rather it's a strategy to treat if and when the prostate cancer warrants treatment. And it is currently the preferred management for men with low-risk prostate cancer and greater than 10 years of life expectancy. It can be used more selectively in favorable intermediate or more aggressive prostate cancers when the life expectancy is relatively short. Surveillance basically consists of repeating PSAs, digital rectal examinations, and prostate biopsies. There's no real consensus on what the optimal surveillance schedule should be. Here at the University of Washington, what we typically do is, at least initially, a PSA every 3 to 6 months, a digital rectal examination every 6 months. We repeat that biopsy within another 12 months or so, and then every 1 to 2 years, initially spreading out over time as we begin to establish stability of the disease within the patient. And then, if more aggressive prostate cancer is identified down the road, we transition to curative therapy if appropriate. And that would typically mean if a patient's upgraded from Gleason 6 to Gleason 7 or greater, but it may also include patients with short PSA doubling times, meaning their PSA is rapidly increasing, which makes us concerned they have more aggressive disease, or if they have a significant increase in the volume of their cancer, even if it's lower grade. We participate in the Canary Pass study, which is a multi-center clinical trial of over 2,000 patients that we've been observing with low-risk prostate cancer. And you can see here, this is looking at time in the bottom in years, and this is the percentage of men for which you have not recommended treatment. And you start out here at 1, that's 100%. You can see that by the time you get out about 10 years, we've recommended treatment in roughly 50% of the men. A little fewer than that number of men have actually undergone treatment, but most men who progress, we do end up treating. But you can see that even at 10 years, about half the patients who started out on active surveillance are able to continue with active surveillance and avoid the morbidity of any potential treatment. In terms of treating prostate cancer, surgery and radiation both remain the gold standard treatments for prostate cancer. They give excellent, relatively equivalent oncologic outcomes with 95% or higher 15% cancer-specific survival. The goals of treatment are cancer control, number 1, preserving urinary continence and function, and maintaining baseline sexual function. You need to realize in considering these treatment options that all treatments for prostate cancer have improved over the years. There are now multiple radiation modalities. Dr. Liao will go over these in more detail. In terms of surgery, we have robotic assisted laparoscopic surgery now, which results in smaller incisions, better pain control, improved blood loss, improved urinary continence, and better ability to perform nerve sparing. And as we'll talk about later, we have the ability to perform focal ablation of prostate cancer in select cases. Which ones should you choose? You know, I think the conventional wisdom out there has been that radiation is less effective, but it has fewer side effects. I think the reality is really the cure rates are very similar in most cases for well-administered surgery or radiation therapy. The side effects between the treatments, however, can differ significantly. Several factors go into choosing your treatment: tumor grade, stage, and how much cancer you have, the volume, the age of the patient and their health status, sexual function, current urinary and bowel symptoms. Prostate size has a big influence on some of the treatments we choose, whether the patient's had previous abdominal or pelvic surgery, or whether the patient's had previous radiation therapy. The important thing to realize is that most men will have several options to choose from in terms of treating their prostate cancer. In terms of prostatectomy, the vast majority of prostatectomies now are performed in a robot-assisted laparoscopic fashion. Generally, it includes a pelvic lymph node dissection. We remove the prostate and the seminal vesicles. Most patients stay overnight in the hospital. They go home with a urethral catheter for 7 to 10 days, and they recover in about 4 to 6 weeks. You can see here, this is the old incision we used to make from the belly button down to your pubic bone. Now we usually do 5 or 6 small pencil-sized holes with a very small incision to remove the prostate. And we often can do nerve sparing if it's acceptable from a cancer control standpoint to try and preserve erectile function. This is a view of the robotic system that we have. It's the Da Vinci system by Intuitive. All hospitals have the same robotic system, as there's only one company right now doing it. You can see there's this console that fits over the patient with a series of arms with insert instruments through these tubes in the abdomen. There's a console here on the side where the surgeon sits and manipulates these arms. This is what the robotic arms look like. They articulate here, 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 and the wrist will rotate as I'll show you. And so you can move it in multiple different directions. There are a variety of instruments that you can insert through these tubes and connect to the robot, you know, with scissors, needle drivers, various graspers, etc. And this is what it looks like from inside the console. Basically, the surgeon has his arms inserted here within the console, and whatever motion he does with his wrist, there's an articulating wrist on the end of the instrument that does the exact same motion. So it's fairly easy to figure out how to do this in terms of hand-eye coordination. There certainly is some skill in terms of learning how to handle the tissue, because you don't have tactile sensation, and you need to rely on visual cues to assess how much attention you're placing on the tissue. So here's the prostate right here. Here's your bladder. Here's the prostate, which sits right at the base of the bladder, in front of your rectum and behind your pubic bone. And essentially what you're doing with the prostatectomy is you're taking out the entire prostate and the seminal vesicles in the back, and then you're reanastomosing the bladder to the urethra down here. We cut across the urethra at this end. And we mentioned nerve spring briefly. The nerves that control erections, or blood flow to the penis, essentially, which controls erections, they start in your low back and they run around the colon. And this is a back view of the prostate, but they run right along the back edge of the prostate on each side, on the right and the left. It's a neurovascular bundle with nerves and blood vessels. Those nerves, if they're preserved, we may be able to preserve erectile function. If you cut those nerves out, we're not going to be able to preserve erectile function. And a lot of this depends on the amount of cancer that somebody has. It's a little bit of a game of chicken, as I tell patients. You want to preserve as much as you can, but you don't want to get too greedy and cut too close to the prostate and not get all the cancer out. Our first goal is always to remove the cancer in its entirety. So erectile dysfunction depends in large part on the patient's age and baseline function. You know, a 50-year-old man who has very good erectile function is going to have much better success than a 75-year-old man who can only achieve a functional erection about half the time. It depends on the, as I mentioned, on the extent of the cancer and the ability to preserve one or both nerves. And there's this ongoing tension between preserving as much nerve bundle as you can and removing all the cancer. This part of the operation is very much dependent on the surgeon and the experience of that surgeon in performing this operation. There's also incontinence risk with a prostatectomy. Most patients slowly recover their continence over the first year, but early on they will have significant leakage when they cough or sneeze or lift something heavy, very similar to what women get after they have children. And they need to exercise their pelvic floor muscles with Kegel exercises to regain their continence. It depends on several things. Risk factors for having long-term incontinence would include older age individuals who have weaker muscles, people who are overweight and have a lot of pressure on their bladder, some men with very large cancers where the cancer may be invading into the sphincter muscle, and finally, whether or not somebody has pre-existing urinary symptoms that are going to predispose them to issues afterwards. Focal therapy is newer, and it's the idea of just treating the tumor and not taking out the whole prostate. The goal is to try and provide long-term cancer control equivalent to traditional therapies of surgery and radiation, but prevent some of the damage by preventing collateral damages. And there are several ways to do this. You can see in this first one is what they call a hockey stick, where you treat about 3/4 of the prostate. There's hemiablation, where you treat half the prostate, or a very targeted focal ablation, where you try and just treat the cancer. And there are a number of energy sources which have been in use or in development, but primarily it's cryotherapy, high intensity focus, ultrasound, or in some cases, laser ablation. You know, the prostate is really an ideal gland for focal therapy. It's very easily imaged and easily accessed through the rectum and the perineum. The big problem we have right now is that current imaging technology, even with modern MRI, is not accurate enough to support ablation technology in many patients. And then there's a question of whether or not focal therapy is adequate. We do this for kidney cancer all the time. Small kidney cancers, you just remove the tumor because the lesion is very focused and a solitary lesion. Breast cancer, it's often not sufficient. They usually would combine a lumpectomy with whole breast radiation or some type of hormonal therapy to treat satellite lesions elsewhere in the breast. And prostate cancer actually resembles breast cancer, probably more so than kidney cancer in terms of having multifocal diffuse disease. You can see here on these pictures, this in the top picture would be an index prostate cancer with really nothing else in the prostate. He would be a great patient for unilateral focal treatment of this lesion. You can get patients with a large index tumor and smaller secondary tumors. This is the type of patient where you would treat the index lesion potentially, but you still have to watch these smaller tumors sort of as we would in somebody with active surveillance. And here's a final picture of somebody with multiple tumor foci, not a clear index tumor. That patient would not be a good candidate for focal therapy. You know, in terms of patient selection, you want somebody with greater than a 5 to 10 year life expectancy. You want them a little higher risk than somebody for which you would propose active surveillance, but maybe a lower risk than somebody for which you would perform prostatectomy or radiation therapy. There's some controversy about doing whole gland versus focal ablation. Certainly when you ablate the whole gland, the toxicity is much higher. And then as we mentioned, you're trying to find the index lesion either through MRI or mapping biopsies. Cryotherapy or freezing the prostate's been around probably the longest, where you put an ultrasound probe in the rectum here to visualize the prostate, and you place multiple freezing probes within the prostate through the perineum and you go through a series of freeze-thaw cycles, which damages the cells by perforating the cell membrane and damaging the vascular supply. You know, how successful that is correlates something with how low you get the temperature, how long you freeze it, the number of freeze-thaw cycles, etc. It's an outpatient procedure. It gives you urinary irritative symptoms for a week or two afterwards. Patients usually go home with a catheter for a few days. Having blood in your urine is very common, and you can get penile swelling and bruising. High intensity focused ultrasound, on the other hand, is ultrasound frequency administered transrectally, where it's focused on a small point within the prostate. And it's usually done with general anesthesia or heavy sedation. It heats the lesion up to greater than 60 degrees centigrade and causes necrosis of the tumor from the heat. It was approved by the FDA in this country in 2015. It's often not covered by insurance, although more and more insurance companies are now covering this. For many years, it was primarily a cash business, which did actually lead to overuse and some questionable indications for usage. But that is largely cleared up at this time. When you do whole gland freezing of the prostate, this is sort of how patients do. You know, most patients have negative prostate biopsies after they've had their gland frozen. The 5-year recurrence rate is just under 80%. Sorry. Incontinence is respectable at 3 to 7%. You know, not that much different from a well-performed prostatectomy. One of the big problems with freezing the whole gland is that most patients become impotent afterwards because you end up freezing those neurovascular bundles, something you wouldn't have if you did more focal treatment. With high intensity focused ultrasound, as a more focal treatment, you know, the failure-free survival was, you know, just under 90%. Most patients don't have a lot of leakage. You know, there's, you know, 15 to 20% patients have a small amount of leakage, but most of them don't need much in the way of pads. And the sexual function can be maintained in the vast majority of the patients because you're not heating the neurovascular bundles to the same extent. There are some new ways of looking at doing focal therapy. There's use of interstitial lasers, where you put a laser fiber in the prostate, heat the prostate through the interstitial laser. You can use photosensitizing agents to make the cancer more sensitive to the laser treatment. Currently, these devices are in clinical trials. So how do you choose your treatment? The first thing is realize that not everybody actually needs treatment, and that one treatment is not right for everyone. Almost everybody will have options. And I think you need to realize that the quality of the surgeon and the radiation oncologist are both important in your potential outcome. I think in summary, the current management of clinically localized prostate cancer offers many diverse options. We're trying hard to balance cancer risk, your patient risk factors, and potential side effects of the treatment. If you choose the patients well, you can try to achieve optimal cancer control and functional outcomes relative to prostate or patient risk factors in most patients. And as imaging improves, I think focal therapy is going to become more and more feasible as a treatment option for prostate cancer. Thank you very much. Good morning. My name is Bill Ellis. I'm a professor of urology at the University of Washington, and I'm going to be talking to you about prostate cancer treatments, primarily focusing on surgical treatments for prostate cancer. By means of disclosure, I am a funded clinical trial study investigator for Nanospectra, which is a focal laser ablation technology company. So briefly, we're going to be talking a little bit about active surveillance or just observing low-risk prostate cancer, radical prostatectomy, and focal therapy. And we'll do a few comparisons between radiation and surgery. But Dr. Liao is going to be talking to you later this morning about radiation, so I won't get into radiation in great detail. The current paradigm for prostate cancer is to try and reduce the burden of localized prostate cancer treatment by not over-treating prostate cancer. So we're trying to balance the risk that the cancer poses with the life expectancy of the patient and the potential morbidity of any treatment that we might undertake. Active surveillance is based on the concept that most men with low-risk cancer don't have something that's likely to harm them. Most men will eventually develop some prostate cancer, and most die with the disease, not from prostate cancer. So the goal is to balance cancer risk with the morbidity of treatment. And it's important to understand that active surveillance is not no treatment, rather it's a strategy to treat if and when the prostate cancer warrants treatment. And it is currently the preferred management for men with low-risk prostate cancer and greater than 10 years of life expectancy. And it can be used more selectively in favorable intermediate or more aggressive prostate cancers when the life expectancy is relatively short. Surveillance basically consists of repeating PSAs, digital rectal examinations, and prostate biopsies. There's no real consensus on what the optimal surveillance schedule should be. Here at University of Washington, what we typically do is, at least initially, a PSA every 3 to 6 months, a digital rectal examination every 6 months. We repeat that biopsy within another 12 months or so, and then every 1 to 2 years, initially spreading out over time as we begin to establish stability of the disease within the patient. And then if more aggressive prostate cancer is identified down the road, we transition to curative therapy if appropriate. And that would typically mean if the patient's upgraded from Gleason 6 to Gleason 7 or greater, but it may also include patients with short PSA doubling times, meaning their PSA is rapidly increasing, which makes us concerned they have more aggressive disease, or if they have a significant increase in the volume of their cancer, even if it's lower grade. We participate in the Canary Pass study, which is a multi-center clinical trial of over 2,000 patients that we've been observing with low-risk prostate cancer. And you can see here, this is looking at time in the bottom in years, and this is the percentage of men for which you have not recommended treatment. And you start out here at 1, that's 100%. And you can see that by the time you get out about 10 years, we've recommended treatment in roughly 50% of the men. A little fewer than that number of men have actually undergone treatment, but most men who progress, we do end up treating. But you can see that even at 10 years, about half the patients that started out on active surveillance are able to continue with active surveillance and avoid the morbidity of any potential treatment. In terms of treating prostate cancer, surgery and radiation both remain the gold standard treatments for prostate cancer. They give excellent, relatively equivalent oncologic outcomes with 95% or higher 15% cancer-specific survival. The goals of treatment are cancer control, number 1, preserving urinary continence and function, and maintaining baseline sexual function. You really need to realize in considering these treatment options that all treatments for prostate cancer have improved over the years. There are now multiple radiation modalities. Dr. Liao will go over these in more detail. In terms of surgery, we have robotic assisted laparoscopic surgery now, which results in smaller incisions, better pain control, improved blood loss, improved urinary continence, and better ability to perform nerve sparing. And as we'll talk about later, we have the ability to perform focal ablation of prostate cancer in select cases. Which one should you choose? You know, I think the conventional wisdom out there has been that radiation is less effective, but it has fewer side effects. I think the reality is really the cure rates are very similar in most cases for well-administered surgery or radiation therapy. The side effects between the treatments, however, can differ significantly. Several factors go into choosing your treatment: tumor grade, stage, and how much cancer you have, the volume, the age of the patient and their health status, sexual function, current urinary and bowel symptoms. Prostate size has a big influence on some of the treatments we choose, whether the patient's had previous abdominal or pelvic surgery, or whether the patient's had previous radiation therapy. The important thing to realize is that most men will have several options to choose from in terms of treating their prostate cancer. In terms of prostatectomy, the vast majority of prostatectomies now are performed in a robot-assisted laparoscopic fashion. Generally, it includes a pelvic lymph node dissection. We remove the prostate and the seminal vesicles. Most patients stay overnight in the hospital. They go home with a urethral catheter for 7 to 10 days, and they recover in about 4 to 6 weeks. You can see here, this is the old incision we used to make from the belly button down to your pubic bone. Now we usually do 5 or 6 small pencil-sized holes with a very small incision to remove the prostate. And we often can do nerve sparing if it's acceptable from a cancer control standpoint to try and preserve erectile function. This is a view of the robotic system that we have. It's the Da Vinci system by Intuitive. All hospitals have the same robotic system, as there's only one company right now doing it. You can see there's this console that fits over the patient with a series of arms with insert instruments through these tubes in the abdomen. There's a console here on the side where the surgeon sits and manipulates these arms. This is what the robotic arms look like. They articulate here, 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 and the wrist will rotate as I'll show you. And so you can move it in multiple different directions. There are a variety of instruments that you can insert through these tubes and connect to the robot, with scissors, needle drivers, various graspers, etc. And this is what it looks like from inside the console. Basically, the surgeon has his arms inserted here within the console, and whatever motion he does with his wrist, there's an articulating wrist on the end of the instrument that does the exact same motion. So it's fairly easy to figure out how to do this in terms of hand-eye coordination. There certainly is some skill in terms of learning how to handle the tissue, because you don't have tactile sensation, and you need to rely on visual cues to assess how much tension you're placing on the tissue. So here's the prostate right here. Here's your bladder. Here's the prostate, which sits right at the base of the bladder in front of your rectum and behind your pubic bone. And essentially what you're doing with the prostatectomy is you're taking out the entire prostate and the seminal vesicles in the back, and then you're reanastomosing the bladder to the urethra down here. We cut across the urethra at this end. And we mentioned nerve spring briefly. The nerves that control erections, or blood flow to the penis, essentially, which controls erections, they start in your low back and they run around the colon, and this is a back view of the prostate, but they run right along the back edge of the prostate on each side, on the right and the left. It's a neurovascular bundle with nerves and blood vessels. Those nerves, if they're preserved, we may be able to preserve erectile function. If you cut those nerves out, we're not going to be able to preserve erectile function. And a lot of this depends on the amount of cancer that somebody has. It's a little bit of a game of chicken, as I tell patients. You want to preserve as much as you can, but you don't want to get too greedy and cut too close to the prostate and not get all the cancer out. Our first goal is always to remove the cancer in its entirety. So erectile dysfunction depends in large part on the patient's age and baseline function. A 50-year-old man who has very good erectile function is going to have much better success than a 75-year-old man who can only achieve a functional erection about half the time. It depends on as I mentioned, on the extent of the cancer and the ability to preserve one or both nerves. And there's this ongoing tension between preserving as much nerve bundle as you can and removing all the cancer. This part of the operation is very much dependent on the surgeon and the experience of that surgeon in performing this operation. There's also incontinence risk with a prostatectomy. Most patients slowly recover their continence over the first year, but early on they will have significant leakage when they cough or sneeze or lift something heavy, very similar to what women get after they have children, and they need to exercise their pelvic floor muscles with Kegel exercises to regain their continence. It depends on several things. Risk factors for having long-term incontinence would include older age individuals who have weaker muscles, people who are overweight and have a lot of pressure on their bladder, some men with very large cancers where the cancer may be invading into the sphincter muscle, and finally, whether or not somebody has pre-existing urinary symptoms that are going to predispose them to issues afterwards. Focal therapy is newer, and it's the idea of just treating the tumor and not taking out the whole prostate. The goal is to try and provide long-term cancer control equivalent to traditional therapies of surgery and radiation, but prevent some of the damage by preventing collateral damages. And there are several ways to do this. You can see in this first one is what they call a hockey stick, where you treat about 3/4 of the prostate. There's hemiablation, where you treat half the prostate, or very targeted focal ablation, where you try and just treat the cancer. And there are a number of energy sources which have been in use or in development, but primarily it's cryotherapy, high intensity focus, ultrasound, or in some cases, laser ablation. You know, the prostate is really an ideal gland for focal therapy. It's very easily imaged and easily accessed through the rectum and the perineum. The big problem we have right now is that current imaging technology, even with modern MRI, is not accurate enough to support ablation technology in many patients. And then there's a question of whether or not focal therapy is adequate. We do this for kidney cancer all the time. Small kidney cancers, you just remove the tumor because the lesion is very focused and a solitary lesion. Breast cancer, it's often not sufficient. They usually would combine a lumpectomy with whole breast radiation or some type of hormonal therapy to treat satellite lesions elsewhere in the breast. And prostate cancer actually resembles breast cancer, probably more so than kidney cancer in terms of having multifocal diffuse disease. You can see here on these pictures, this in the top picture would be an index prostate cancer with really nothing else in the prostate. He would be a great patient for unilateral focal treatment of this lesion. You can get patients with a large index tumor and smaller secondary tumors. This is the type of patient where you would treat the index lesion potentially, but you still have to watch these smaller tumors sort of as we would in somebody with active surveillance. And here's a final picture of somebody with multiple tumor foci, not a clear index tumor. That patient would not be a good candidate for focal therapy. You know, in terms of patient selection, you want somebody with greater than a 5 to 10 year life expectancy. You want them a little higher risk than somebody for which you would propose active surveillance, but maybe a lower risk than somebody for which you would perform prostatectomy or radiation therapy. There's some controversy about doing whole gland versus focal ablation. Certainly when you ablate the whole gland, the toxicity is much higher. And then as we mentioned, you're trying to find the index lesion either through MRI or mapping biopsies. Cryotherapy or freezing the prostate's been around probably the longest, where you put an ultrasound probe in the rectum here to visualize the prostate, and you place multiple freezing probes within the prostate through the perineum, and you go through a series of freeze-thaw cycles, which damages the cells by perforating the cell membrane and damaging the vascular supply. You know, how successful that is correlates something with how low you get the temperature, how long you freeze it, the number of freeze-thaw cycles, etc. It's an outpatient procedure. It gives you urinary irritative symptoms for a week or two afterwards. Patients usually go home with a catheter for a few days. Having blood in your urine is very common, and you can get penile swelling and bruising. High-intensity focused ultrasound, on the other hand, is ultrasound frequency administered transrectally, where it's focused on a small point within the prostate. And it's usually done with general anesthesia or heavy sedation. It heats the lesion up to greater than 60 degrees centigrade and causes necrosis of the tumor from the heat. It was approved by the FDA in this country in 2015. It's often not covered by insurance, although more and more insurance companies are now covering this. For many years, it was primarily a cash business, which did actually lead to overuse and some questionable indications for usage. But that is largely cleared up at this time. When you do whole gland freezing of the prostate, this is sort of how patients do. Most patients have negative prostate biopsies after they've had their gland frozen. The 5-year recurrence rate is just under 80%. Sorry. Incontinence is respectable at 3 to 7%. Not that much different from a well-performed prostatectomy. One of the big problems with freezing the whole gland is that most patients become impotent afterwards because you end up freezing those neurovascular bundles, something you wouldn't have if you did more focal treatment. With high-intensity focused ultrasound, as a more focal treatment, the failure-free survival was, just under 90%. Most patients don't have a lot of leakage. There's 15 to 20% patients have a small amount of leakage, but most of them don't need much in the way of pads. And the sexual function can be maintained in the vast majority of the patients because you're not heating the neurovascular bundles to the same extent. There are some new ways of looking at doing focal therapy. There's use of interstitial lasers, where you put a laser fiber in the prostate, heat the prostate through the interstitial laser. You can use photosensitizing agents to make the cancer more sensitive to the laser treatment. Currently, these devices are in clinical trials. So how do you choose your treatment? The first thing is realize that not everybody actually needs treatment, and that one treatment is not right for everyone. Almost everybody will have options. And I think you need to realize that the quality of the surgeon and the radiation oncologist are both important in your potential outcome. I think in summary, the current management of clinically localized prostate cancer offers many diverse options. We're trying hard to balance cancer risk, your patient risk factors, and potential side effects of the treatment. If you choose the patients well, you can try to achieve optimal cancer control and functional outcomes relative to prostate or patient risk factors in most patients. And as imaging improves, I think focal therapy is going to become more and more feasible as a treatment option for prostate cancer. Thank you very much.
Hi, I'm Dr. Liao. I'm a radiation oncologist at the University of Washington Fred Hutchinson Cancer Center. It's a pleasure to join you here today. I want to thank the event organizers for inviting me, and I'd like to thank patients, families, and others interested in prostate cancer that are joining us here today. I'll be talking today about advances in radiation therapy for prostate cancer. And this is a difficult topic to cover in a short span of time, but I hope today to give you an overview of the range of radiation options for localized prostate cancer. We'll talk about advances in external beam radiation therapy. I'll talk to you a bit about the status of proton therapy and about the important concept of hypofractionation, which is delivery of higher doses of radiation and fewer sessions of treatment. Tied to that is the technique of stereotactic body radiation therapy, which is delivery of radiation therapy over just 5 sessions of radiation. We'll talk about some of the complementary technologies now that we're utilizing in the delivery of radiation, and a bit about some of the key studies and trials with work ongoing at our institution and others. Prostate cancer is the most common cancer diagnosis in men. Most have localized disease. And our patients are faced with deciding amongst numerous treatment options, including surveillance, which is appropriate for many, surgery or radiation therapy when it comes to treatment. And there's a variety of techniques of how to deliver radiation. In some patients, the addition of hormonal therapy or androgen deprivation therapy may be indicated. Given the low rates of cancer mortality, fortunately, the priority for many of our patients, understandably, is reduction in toxicity and maximizing quality of life and minimizing interruptions in their lives. There's a whole alphabet soup of terminology and acronyms that we use in radiation oncology. So I give you this just as a handy reference to use for this talk and just for your own reading and reference with terms that are pertinent to external beam radiation therapy, to brachytherapy, and some miscellaneous terms that are used commonly. So this is a broad overview roadmap and a way that I think about presenting the treatment options with radiation to my patients. So radiation can be given as external radiation or as internal-based radiation. External beam radiation can be administered as X-ray based treatment, which is called IMRT, or intensity modulated radiation therapy. This is delivery of radiation in outpatient sessions daily, generally over about 4 to 8 weeks of treatment. Using specialized techniques, this same form of treatment can be delivered with a technique called stereotactic body radiation therapy, which is delivering treatment over just 5 sessions of very high dose radiation, usually administered over 1 to 2 weeks of treatment. And then radiation can be given as well using particle beam radiation, and proton therapy is the most common technique there. And that's also typically given over about 4 to 8 weeks of treatment, similar to IMRT. And there's internal forms of radiation that are using radiation sources, either permanent or temporary, with what's called low dose rate brachytherapy or high dose rate brachytherapy. In certain patients with a little bit more unfavorable, higher risk cancers, we sometimes use combined approaches that use sort of external beam radiation therapy in addition to brachytherapy. And in some patients with higher risk profile cancers, the addition of hormonal therapy is standard of care. Here are some potential side effects with radiation. Much of this applies across the range of radiation treatment options. And some of these are more common and expected, while some are less common. Of course, each patient is individual, and the reality can vary quite a bit from person to person. In terms of urinary effects of radiation, it's common to have irritated bladder symptoms, and this can consist of frequent or urgent urination, some stinging or burning with urination, reduced urinary stream. Fortunately, less commonly do we see issues in the long term with incontinence, scar tissue of the urethra called urethral stricture, or radiation inflammation or damage of the bladder called cystitis. Bowel effects are common, with many patients experiencing looser stools or bowel urgency. And fortunately, in the long term, it's less common to see issues like rectal bleeding or damage or radiation damage to the rectal wall called proctitis. Sexual side effects are common with any sort of prostate treatment, including radiation, and we do see erectile dysfunction and diminished ejaculate. And some of these effects are expected with age, but radiation can be thought of as sort of accelerating the normal age effects that we would see over time. And this can certainly be compounded with addition of hormonal therapy in many patients that are receiving it. Some element of fatigue is common with treatment, but many of our patients are able to continue with work and to be active. Unfortunately, late secondary malignancies related with radiation are quite rare. Brachytherapy has been around a long time, so this is the placement of radiation sources into the prostate. This is most commonly done with LDR, or low-dose rate brachytherapy, which is permanent implantation of radiation seeds that slowly give off the radiation over the course of months to about a year or so. This is done as a same-day procedure along with our urologic colleagues in the operating room, typically under general anesthesia. Some facilities do perform this as in-clinic procedures. And there's something called HDR, which is high dose rate brachytherapy. And this is using a radiation source and then temporary placement of catheters into the prostate over a series of several sessions done in the clinic and under sedation. HDR can, but is not as often used for monotherapy or by itself, but it is combined in some cases in certain patients with higher risk profile cancer as a combined approach. We do use HDR in select patients as a salvage therapy for recurrences. External beam radiation is how we deliver much of prostate radiation nowadays, and significant advances have occurred with technological advance in the safe delivery of external radiation. So we're able to deliver the radiation with minimizing exposure to the bladder and to the rectal area and to minimize side effects. We've come a long way from two-dimensional design of radiation fields based on fluoroscopy X-ray images, and we, in the past, used simple metal blocks actually for shaping the radiation fields. And then significant advance came with the advent of CT scan-based planning and development of 3D conformal radiation therapy. This is a technique that's still used in many situations of doing palliative radiation or when we're doing radiation therapy to lower doses. And it still remains a standard for definitive prostate radiation in many places in the world. This is where we're at here. IMRT is our main core for a lot of therapy radiation that we do for prostate cancer as well as other cancers. And this is utilizing radiation fields that come from many angles around, about 5 to 9 different angles with numerous small radiation field shapes. So we're able to very highly spatially conform the radiation dose to the prostate, much more than in the past. Refinement to that is called VMAT, or volumetric modulated arc therapy. And this is a type of IMRT that's using a continuous arc with movement of the radiation machine or linear accelerator to deliver even more radiation field segments. So the treatment can be delivered over faster treatment sessions and even further improvement in our conformality of the radiation dose. Nowadays, most prostate IMRT in the US is delivered with the VMAT approach. And then with specialized techniques, actually using this same approach is how we deliver what's called stereotactic body radiation therapy or even higher dose radiation over very few sessions. And I'll talk a bit about that. Another way to deliver the radiation with external radiation is using a specialized type of particle beam radiation called proton radiation. And this has unique dose characteristics compared to X-ray treatment, where basically protons deliver most of their energy at a very sharp stopping point. So treatment can be delivered with very few radiation beams and less exposure to some of the surrounding areas. Because of the large infrastructure needed for these facilities, it was limited to just 2 sites in the US for a long time, the Massachusetts General Hospital and Loma Linda Cancer Center. And proton therapy itself over this period of time has advanced where we deliver it now something called pencil beam or spot scanning and with daily image guidance. So now there are about 30 facilities in the US and across the world, about 100 particle therapy facilities. And this now has an established track record in about 200,000 patients treated overall across many different cancer sites, including prostate. We've had our facility here at UW Fred Hutch since about 2013. So what is the advantage? The advantage in prostate radiation is some reduction in radiation dose to the bladder and the rectal area that we're trying to spare, mainly in the medium to low dose radiation exposure. How much this translates into a potential reduction in side effects experienced by patients compared to X-ray based therapy is still being carefully evaluated. Multiple single institution experiences with proton radiation have been reported, but there's no mature randomized head-to-head studies yet comparing this with X-ray based approach. Here are a couple key studies that are examining this question. The PARTIQL study is a randomized multi-center trial. That's a direct head-to-head comparison of proton radiation versus IMRT radiation. 12 proton centers participated in the study, including ours, and this recently completed accrual in late 2021 with about 450 patients randomized. So we're hoping from this, as well as other studies, that we'll have a better understanding of the comparative side effects between these techniques, and we await longer term follow-up before the first analysis. Also ongoing and still open right now is a study called the COMPARE trial. And this is a larger study of about 3,000 patients led by the University of Florida. It's not a randomized trial, but this is a study at some higher volume US centers taking about 3,000 patients treated with either proton beam radiation or IMRT and closely tracking and monitoring the outcomes as well as patient quality of life measures. Let's talk a bit about the important concept of hypofractionation. Over the past 20 years, on the basis of evidence showing improved cancer control with higher dose of radiation, standard radiation treatment courses became quite long over the past number of years to about 8 to 9 weeks of daily treatment. And this can be a significant burden for our patients in terms of time away from work and family and the cost. So a lot of work has been done to look at seeing if we could deliver higher dose of radiation safely and in fewer treatments. Given some unique aspects of the biology of prostate cancer, there's reason to believe that this potentially could help improve the therapeutic ratio. In other words, maintain or improve cancer control while maintaining similar to potentially even reduce side effects. So far, the available evidence does not show any clear superiority as far as tumor control. So we've shifted the focus over the past number of years on looking at measures like patient convenience and cost effectiveness, and trying to see if we can maintain similar cancer control with these courses of shorter course radiation, but without increasing side effects or toxicity. So now there are multiple completed as well as a lot of ongoing studies in both X-ray and proton-treated patients looking at this question. This is a simple breakdown of how we think about radiation treatment schedules. Conventional fractionation was a tried and true regimen that we used for many, many years. This is treatment in lower doses of radiation given over about 8 to 9 weeks of treatment. Moderate hypofractionation is moderately reduced course radiation, but slightly higher doses. This is treatment given over 3 to 5 weeks of treatment. And this now is the most common regimen used at our institution on the basis of evidence, which I'll go over in a bit. Extreme hypofractionation, which is also called ultra hypofractionation or SBRT, is delivering even higher dose of radiation and over a very short course regimen over either 1 to 2 weeks of treatment, usually done in just 5 treatment sessions. So where are we at with understanding this? So moderate hypofractionation, which is the medium reduced treatment schedule, usually over 4 to 5.5 weeks. In this area, there are numerous large randomized trials that have been reported in the past several years, largely showing that there's equal efficacy here, cancer control, and similar, not exactly the same, but very similar toxicity measures as far as urinary and bowel side effects compared to longer schedules of radiation. There's also multiple single institution series now reported with similar approach using proton radiation. So now on the basis of this evidence, this is endorsed by many guidelines, including the NCCN or National Comprehensive Cancer Network as a preferred regimen for delivery of radiation. At our institution now, either with photon or X-ray treatment or proton radiation, this is now the most common regimen that we utilize. But how about even shorter course radiation? So this is called SBRT or ultra hypofractionated or extreme hypofractionated treatment. This is typically given in 5 treatments over 1 to 2 weeks. And this can be delivered a couple different ways. One is with specialized techniques using the platform of treatment we use to deliver IMRT or VMAT radiation, so conventional linear accelerator platform, or with CyberKnife, which is a type of robotic platform delivery of this radiation. So now accumulated evidence mainly from single institution experiences, mostly limited to about 3 to 5 year follow-up outcomes, have shown that this may be a safe way to deliver the radiation. On prospective, well-done studies, about 6,000 patients now have been reported in some analyses with expected results as far as cancer control, and so far relatively favorable toxicity profile that we've seen. Several randomized trials now have been completed examining this question. 2 important ones from the Europeans that are listed above here. The HypoRT-PC study compared 7-fraction SBRT type approach treatment versus a more conventional 8-week treatment regimen. This one is the longest follow-up of a randomized trial, and at 5 years so far, so there was no difference in late urinary or bowel side effects. In the short term, there were some measures of acute urinary and bowel side effects that were a little bit worse with SBRT approach. And then very recently, 2-year outcomes from this PACE-B trial were reported, which was comparing 5-fraction SBRT versus either conventional or moderately fractionated treatment. There was an equally low rate of any serious urinary and bowel side effects, but there were some measures of urinary toxicity that seemed to be a little bit worse with SBRT. So how about SBRT with proton radiation? Well, that's been looked at in a small study that compared 5-fraction proton SBRT versus a 9-week course of conventionally fractionated protons. So far, just early follow-up has been reported, but at 18 months, there were no significant differences in urinary or bowel toxicity. There's numerous ongoing studies that are examining this further. The PACE-A study is a really interesting study that'll be comparing SBRT versus surgery. And then there are 2 studies that will be very key studies looking at a comparison of SBRT versus moderate hypofractionated IMRT. And then several studies are further evaluating this question of whether SBRT or very short course radiation can be delivered with proton radiation. So we have begun to offer SBRT in our proton-treated patients here. Most of our patients are treated on a prospective registry trial that's treating with very consistent treatment approach and closely monitoring and tracking side effects after treatment. There's varying perspectives as far as whether the status of SBRT is high enough to offer this routinely now at this time. But overall, the patterns of care are showing more and more utilization of SBRT as we're understanding the safety and efficacy of this better. And multiple guidelines now do endorse that SBRT may be considered as an option. Importantly, the late toxicities theoretically could be worse with progressively hypofractionated regimens. So longer follow-up is certainly awaited, and enrollment in prospective trials is definitely encouraged so that we can understand this better. Brief mention that SBRT may have other applications, for instance, in patients with advanced disease. There's a rapidly evolving space called metastasis-directed therapy, which is basically using SBRT to deliver very high doses of radiation to focal sites of metastasis, which we can do nowadays in many situations with minimal toxicity. These were patients here where we treated a site of rib metastasis with SBRT, lymph node recurrence, an unusual picture of lung metastasis from prostate cancer. A number of these patients were actually treated on clinical trials looking at using advanced molecular imaging or PET scan to direct treatment. There's a variety of complementary technologies now that have improved our ability to target the prostate. So this is called image-guided radiotherapy. It's common now to place markers into the prostate or fiducial markers, usually under ultrasound guidance and in the clinic. And then there's various techniques we can use nowadays to image and then to localize and align to the prostate each day. We commonly utilize cone beam CT scan, which is built-in onboard low-dose CT scan. And there's also a technique of placing electromagnetic frequency markers called Calypso that allow continuous tracking. A very nifty innovation that was developed a couple years ago is the introduction of hydrogel rectal spacers. So this is placing a water-based biocompatible hydrogel spacer into the space in between the back of the prostate and the front of the rectal area. Places a minimally invasive same-day procedure, and this basically displaces the rectal area a little bit further away from the radiation fields and allows some decrease in the radiation exposure. There was a trial that showed that this could help diminish rectal pain and bleeding in some patients. And so we have begun to use this since about 2015 or so at our institution. Right now, the patterns of practice vary, and not everyone requires this, and optimal patient selection for who benefits the most from this is still being defined. Focal boost to the prostate, treating with added booster radiation to sites of prostate cancer within the prostate is something that's being looked at as well, which is very interesting. There's a study called the FLAME trial. That was a small randomized trial looking at MRI to guide added boost of radiation to subvolumes of areas within the prostate to see if this can help improve cancer control. And this did show a small improvement in PSA control rates, importantly, without an increase in toxicity. And these strategies still treat the entire prostate, but basically give an added boost of radiation, zeroing in on areas that we know are involved with cancer based on MRI scan and biopsy. Quickly with a couple slides, just looking at the rapidly evolving space of adaptive treatment. As we know, the human body is not static, and each day the anatomy is slightly different, and the prostate may have small anatomical changes in the pelvis related to variations in the bladder and the rectum each day, even from moment to moment. And traditionally, we've planned radiation based on a single CT scan snapshot in time. Now there are technologies being developed to customize the treatment even further. So this is something that we'll have at our institution a little bit later this year. It's called the Variant Ethos platform. It basically has onboard imaging with high quality cone beam CT scan imaging to assess daily patient anatomy. And it's able to actually adapt the treatment plan and revise within minutes in order to custom tailor the treatment on a daily basis with what the anatomy looks like. Then interestingly, it'll be incorporating aspects of artificial intelligence enhanced treatment planning. Several systems now are available that are incorporating MRI scan to the treatment platform, and MRI generally has better soft tissue resolution and definition of the prostate compared to CT scan. And we use diagnostic MRI scan frequently now to assist with treatment planning. These systems actually incorporate diagnostic quality MRI scan within the linear accelerated treatment platform. This allows not only adaptive re-optimizing of the daily treatment plan to account for the daily anatomy, but also allows real-time 3D anatomic tracking of the prostate while the treatment is being delivered. There's a couple platforms now available at a few centers now looking at this technology. A small study by the UCLA group did show that MRI guided treatment compared to CT scan guided treatment in patients receiving prostate SBRT had some measures of urinary toxicity that seemed to be somewhat reduced. So it's still an unanswered question whether the addition of some of these technologies reduce side effects in a meaningful way. But a lot of exciting ongoing work will be done in this space. So in conclusion, there's a wide variety of modern radiation options for localized prostate cancer, and significant technological advances have made it possible to deliver radiation to the prostate safely while diminishing exposure to surrounding tissues. Recent studies have demonstrated that radiation treatment courses can be delivered safely in many patients over fewer treatments. There's ongoing studies that are focused on further customizing treatment to each individual, even on a daily or real-time basis to the prostate. Strategies to further decrease side effects are ongoing, and there's a lot of studies that are evaluating comparative toxicities across these different treatment strategies. So I'd like to thank the other members of our radiation oncology GU team here, and thank you for your attention.
Hi, colleagues and patients and friends. I want to thank everyone for having me here today to talk about management of the PSA relapse or recurrence, as well as active surveillance. So in this discussion, we'll talk about how we define PSA recurrence, what is androgen deprivation therapy, and why do we use it in PSA recurrence. I'm going to provide you some new information provided at a national meeting, international meeting actually in Europe in September of this year. We'll talk a little bit more about the side effects of androgen deprivation therapy, and we'll finish on a very different topic of active surveillance. What is a PSA recurrence? You know, in most cancers, we don't have a blood marker. If you had lung cancer and then had part of your lung taken out to try to cure it, you would just be followed with imaging studies, probably CT scans to see if the cancer came back. But in prostate cancer, we do have a pretty good marker of the prostate cancer activity called the PSA, or prostate specific antigen, which is found in the blood. So you can have patients who have no evidence of cancer on imaging, but still have PSA in the blood, and therefore you know that the cancer has returned. Notably, you know, our imaging studies are changing to get more sensitive, so we'll be able to pick up a grain of rice, whereas now we can just pick up sugar cube size. And also importantly, when I talk about this, I mean people who've had a radical prostatectomy to remove the prostate or radiation to the prostate. So some attempt at curing it. What is the definition? It's a little easier to define after surgery. It's a PSA of 0.2 or higher. And after radiation, it's a little more complicated because the radiation may not kill healthy prostate tissue. So sometimes after radiation, the PSA can come up a little bit, but it should really come up a little and then plateau and not continue to rise. And if it does, that could mean that the PSA or the cancer is back after the radiation. Here's an example of someone who has PSA recurrence. It's a 71-year-old man diagnosed with prostate cancer in 2013. He gets a radical prostatectomy to surgically remove his prostate. It shows Gleason 4+4 disease and no lymph nodes involved. And after his surgery, his PSA goes down to undetectable. However, 3 years after his surgery, his PSA is detectable at 0.1. And then a couple months later, it's 0.5. So what does that mean? It means, simply put, that taking out the prostate did not cure his cancer. Perhaps there were some cells in other places of the body that weren't taken out or couldn't be taken out. And now the cancer's back. So what is the natural history? Like, let's say we have 100 patients and all of them had their prostates taken out, and we're going to follow them along to see what happens. So that's what these guys did. They looked at 2 decades of data from Johns Hopkins University and found 315 men who had had a biochemical recurrence after surgery. 11 of those 315 men got hormone deprivation therapy, which many of you are on, I'm sure. But the other 311, I'm sorry, the 304 did not. So what happened to those 304 men? Well, after being followed, like with labs for 8 years, a third of them did go on to get metastatic disease, a tumor that could be seen on imaging. So that means 2/3 of them did not. So there's a wide range of outcomes here. After surgery or radiation to cure the prostate cancer, it's possible that the cancer will come back and potentially take a person's life. But it's also possible the PSA will start rising and it won't have any bearing on life expectancy. So the thing that seems to be most important in knowing whether or not this PSA recurrence is a problem is looking at how quickly the PSA doubles. How long does it take to go from 2 to 4, 4 to 8, 8 to 16, etc.? If it takes 3 months to double, then that's a bad sign. If it takes 1.5 years to double, then that's a good sign. The guy whose PSA doubles every 1.5 years probably won't die of prostate cancer. I mean, there are exceptions to that. The guy whose PSA is doubling every 3 months has a good chance of dying of prostate cancer because that person will go on to develop metastatic disease, and that's a lethal form of prostate cancer. So in the setting of biochemical relapse, we typically do give an injection, either in the fat of the abdomen or in the muscle, like the buttock, to turn off the testicles. We know that prostate cancer thrives on testosterone, and that when we turn off the testicles, it initially shrinks and the PSA goes down. However, we also know there's real side effects and consequences to giving people this form of therapy. Here's a list of them. The ones that we talk about the most are first, bone density loss, because we do not want our patient to survive with prostate cancer, but then have a hip fracture and have a bad outcome from that. So patients do get, and you should be getting, a bone density study every 1 to 2 years. You should be encouraged to take calcium and vitamin D, calcium 500 to 600 milligrams twice a day, and vitamin D, I would say at least 1,000 international units, but up to 5. And please don't overdo that. Choice at the grocery store. You don't want to be loading up on the Cocoa Puffs. I mean, I'm guilty of that. But everything changes when you're on this therapy. Your metabolism changes. So that bowl of Cocoa Puffs could lead to 5 pounds added in your body weight. Try to stick to produce, fresh fruits and vegetables. Some of my patients get like an emotional lability, I would call it, like their mood is kind of shifting. So I don't have a lot of patients who get real depression, I would say. muscle loss. So please do exercise. The penis and testicles shrink and the desire to have sex goes away. So it's important to just know that when you embark on this therapy. The most important thing you can do is really continue to have a good relationship with your primary care physician. We prostate cancer doctors, we're good. We know prostate cancer, but we're not up to date on the new shingles vaccine and what age you should get your pneumovax vaccine. We can't keep up with everything. So do exercise, take your calcium, vitamin D, be careful about what you eat, and see your primary care physician. So what is salvage radiation? So let's say that person we talked about who had surgery in 2013, then has his PSA increase, and there's a possibility after surgery that the cancer is still in the pelvis. So in that situation, if you give radiation to the pelvis, it's possible you can mop up the remainder of the cancer cells and have a second chance at cure. A lot of people do undergo radiation for this circumstance, and it's not, oftentimes it doesn't work, but a lot of times it's worth it, because if it does work, that's important. There are some predictors of whether or not it's going to work. One of the most important ones is margin status. So after the prostate is taken out and it's sent to the lab for inspection, does the pathologist look under the microscope and see that the tumor cells go right up to the edge of the prostate? And if that's true, it's possible that the surgeon cut through some of the prostate cancer cells and that some may be left in the pelvis. So in that situation, considering salvage radiation is really, really important. For a long time, we gave salvage radiation without anything else. But this study changed that. So now we give hormonal therapy with salvage radiation therapy. Usually it is a shot, but it started out with this paper in 2017 talking about bicalutamide, which is an oral medication that blocks the androgen receptor in the prostate cells. And I'm going to show you that in a minute. This study actually showed that people live longer, and they're less likely to develop metastatic disease if they take the bicalutamide. However, they are also more likely to have breast enlargement. So if we look here at the results, you can see that for metastatic prostate cancer, meaning the cancer went ahead and spread, after, for the patient in the bicalutamide group, it was 14.5% versus placebo was 23%. So it's more likely that cancer would become metastatic or form a tumor somewhere outside the prostate in the patients who did not get the bicalutamide. And then death from prostate cancer was also significantly decreased in the group that received bicalutamide. Now, I promised some news. For many years, I gave this talk and there was not a lot of change. And recently it's become an active part of prostate cancer exploration. So this is a trial that we did have open at OHSU. It's called Presto, and it looked at people who had radical prostatectomy to try to cure the cancer, but then unfortunately developed metastatic disease. I'm sorry, biochemical relapse. So these patients were randomized in a 1-to-1-to-1 fashion, meaning equal numbers, to a shot to decrease the testosterone, or a shot plus apalutamide, which is an advanced form of bicalutamide, or the shot plus apalutamide plus abiraterone. Abiraterone blocks male hormone production by the adrenal glands. These patients got 13 weeks of treatment. It's about, it was 13 months. So it's about a year of treatment. And then they were followed up. Basically, everyone stopped the treatment and then they followed people to see how long it would take for the PSA to come back up. And when they compared the shot alone to the shot plus apalutamide, they saw that the time to the PSA coming back up was delayed in patients who got apalutamide as well as the shot. And then they compared the shot alone to patients who got apalutamide plus abiraterone. So like a triple treatment here. And they found again that it took longer for the PSA to go up. So specifically, it took a median of 26 months for it to come back up again after stopping the therapy versus 20 months for the shot alone. So what happens when someone's PSA is going up and it's doubling, let's say every 3 months, and the doctor and patient talk and say, I think we should put you on something because I'm worried your cancer is going to become metastatic. And they put you on a shot, let's say Eligard. And for a long time, the PSA is undetectable, but then unfortunately it starts to creep up again. That happened to this gentleman here. So his PSA initially increases to undetectable, but then it starts to climb, even though he's still on the shot. I mean, you can check his testosterone is very, very far down low. There are actually new treatment options as of maybe like since 2017, I think they became available. Enzalutamide, darolutamide, or apalutamide. They all block interactions with the androgen receptor. They all delay the time to metastatic disease, help the PSA come down, and most importantly, help people live longer. However, they all also add toxicity, including financial. These are expensive medications. And I like this cartoon because it just kind of gives you a brief overview of where treatments are acting. So all three of these drugs act by interrupting like the binding of the male hormone to the androgen receptor, its movement into the nucleus, and its binding to the DNA. Once this binds to the DNA, it starts making cells multiply. So this drug is, these three drugs, they work about the same. They all work there. And there's another drug I mentioned earlier, abiraterone, and that works at the level of the adrenal gland. So you can either block the interaction with the male hormones and the androgen receptor, or decrease the amount of circulating male hormones. Active surveillance. So we know that people often die of prostate cancer, not, or with it. I said it backwards. People die with prostate cancer, not of it. And if you look here at this graph, you see Gleason score of 6, which is considered relatively low risk. In an older gentleman population, these patients, the light gray is death from any cause, and the dark gray is death from prostate cancer. So they're much more likely to die of something else than they are of prostate cancer in this picture. Whereas those with very aggressive cancer, Gleason score 7 to 10, are much more likely to die of prostate cancer than something else. So when it comes to talking to patients about treatment, and you look at this information here, you think, well, it's those patients in the square shape that I really want to treat aggressively. And that's true, because every time you remove a prostate from someone who is never going to die of prostate cancer, you give him side effects like erectile dysfunction or urinary incontinence without helping the lifespan. So active surveillance is good for people who have not so aggressive prostate cancer. It involves a combination of doing biopsies to see what the Gleason score is, PSAs, and digital rectal exams. And if the cancer appears to be getting more aggressive, let's say you do a biopsy and it's Gleason 6, and then in a year you do another biopsy and it's Gleason 7, then you move on to radiation or surgery. I have these are in your printouts, just different protocols according to institution. But I also want to mention that, that it seems to work, this active surveillance. And in a group of nearly 1,000 men who were put on an active surveillance protocol, 2.8% developed metastatic disease. So that's not something you want to see. But that means 97.2% of men did not. And there were 1.5% of patients who died of prostate cancer. So nearly 99% did not. So it does save people side effects and hopefully catches the dangerous cancers. Thank you so much for your time.
Well, good morning, and my name is Dan Lynn. I'm at the University of Washington Urology Department, and I want to thank the meeting organizers for inviting me to speak. And today I'll be discussing high-risk newly diagnosed prostate cancer. And for those of you that were here last year, I was assigned a similar topic, but I'm going to change it up a little bit. And I think that in the last year, there's been many developments, and so I want to bring you up to speed on that. So for the sakes of today, I have this as the agenda. First, I think there's always room to educate and just review how we determine really what is high-risk prostate cancer. I spend the majority of my time discussing maybe new developments with regards to what is the current and emerging way that we evaluate patients who are just diagnosed with high-risk prostate cancer, and then what are the treatment options. I'll end with some future directions, which I think are really relevant for all of us in the Pacific Northwest, because we are leading many of these trials. And again, they're very relevant for what we do in patients who are diagnosed with this type of cancer. So first, what is high-risk prostate cancer? And I think, again, we can whip through this fairly quickly because I'm sure many of you know this already, but there are several factors, of course, that we look at in how we determine what the stage is or what the factors that affect prostate cancer behavior. And the first one is stage. So that's what we might feel on a digital rectal examination. Not really that accurate, I think, in general, because many prostate cancer patients have normal exams. The big one is grade, which is what the cancer, of course, looks like on the microscope. It's a so-called Gleason grading scheme. There's also, of course, how high the PSA is or how low it is, hopefully, for most patients newly diagnosed. But in high-risk prostate cancer is usually high. And then there's nuances that we get from the biopsy. And that might be how many biopsies had cancer, how much of each biopsy had cancer, and those types of information. And I kind of put it together all on this slide. So again, the first thing we do is look at the grade grouping. We used to have just 6, 7, 8, 9, 10. And I think many of us now think about it in terms of 1 through 5. Grade 1s or grade group 1 is with the Gleason 6 the lower scale, but then all the way up to grade group 4 and 5, which have in the other Gleason scale 8, 9, or 10. So that's a high Gleason. PSA is either less than 10, maybe 10 to 20, or over 20. Over 20 is considered high. And then, of course, we look at where is it in the prostate? Is it just in one area, or is it in more than one area? Or as you can see on the screen there on the right side of the screen, almost all the whole prostate. And those little pieces we take out, how much of each of those little pieces. And when I speak to my patients and see many patients who just found out they had cancer, I might draw a line here and I say, if you're on the right side of that line, then you have what we call high-risk prostate cancer. So that's what we're going to talk about for the next 15 minutes or so, are men who fall in that category. And we basically say that they're good for trials if they're that category. Of course, on the bottom line there, if they're really low, they get surveillance. And if they're in the middle, we go for treatment. There is the so-called AUA or NCCN risk groups. And again, they have the following same criteria: PSA, Gleason grade, stage of prostate cancer. And again, what we're going to focus is up here: higher PSAs, higher stages, higher Gleason scores. And the question is what to do about them. So that's just a quick review. Since in the last year, there have been some emerging developments, mostly in recommendations for how we evaluate patients after they're diagnosed, and even some advances in how we treat them. And I'm going to review that. This is kind of more newer data. There is a group that is called the AUA, or the American Urological Association. In the AUA, I'm part of the AUA guideline group, and they get together and we've developed guidelines and what we call them the AUA guidelines. And this is just the AUA guidelines. It just came out within the last few months. And it's a long list of 30 or 40 statements. And I'm just going to have a few of the statements written here because they're relevant for this discussion today. One of them is clinicians should obtain a bone scan or a pelvic MRI or CT scan for patients with high-risk prostate cancer. So a bone scan and an MRI or a CT scan for patients with high-risk prostate cancer. It stands to reason. I think it's a pretty natural thing that we all do to stage patients. The newer statement on this guideline that came out was this one: in patients with prostate cancer at high risk for metastatic disease with negative conventional imaging, in other words, negative CT and bone scan, clinicians may obtain molecular imaging to evaluate for metastasis. So what is that? What is molecular imaging? And again, this is may, it doesn't have to. So again, in patients who have high-risk prostate cancer, but look like they have pretty bad disease, clinicians can obtain molecular evaluation to look for metastasis. And what is that again? That's like PSMA PET. And I think many of you heard about this. This is using a radio-labeled tagged antibody. It's a specialized scan. And this was one of the pivotal studies. There were multiple of them. I'm just showing one of them. This is almost 800 patients who, now some of them had the middle of my page, they're intermediate risk, but many of them had high risk prostate cancer. And they all underwent this scan. And a couple things. One is that the scan found disease in places like the bone and lymph nodes that regular CT and MRI and bone scans didn't. Secondly, it sometimes lit up little pelvic lymph nodes, and many of them, here almost 300, underwent surgery. And in those men that underwent surgery, a fair number of them, almost 1 in 5, had a positive scan, and more than that actually had nodes that were positive. So it didn't detect every little node that had cancer in it, but if you look at kind of the real true test in the statistical terms, the positive predictive value, in other words, if the test was positive, how often was it truly positive? Well, 75%. What's more telling is if the test was negative or negative predictive value, that at least 80% of the time, there truly wasn't anything there that was away from the prostate. This was one study. Again, there are multiple others that maybe even show a little bit better performance. And I think the field is going towards having maybe even PSMA PET scanning replacing standard bone scan and CT. And we can discuss this in the question and answer session, and you'll hear more about it later today. The guidelines go on to say this: clinicians should perform an assessment of patient and tumor risk factors to guide the decision to offer germline testing that includes mutations known to be associated with aggressive prostate cancer and or known to have implications for treatment. I'm going to leave it there because Dr. Cheng today will talk at length about what we call germline testing, and that's what you inherit from your parents. It's the DNA that you inherit that might have variations. Some people call them mutations, but I like to say they're variants of genes that are associated with aggressive prostate cancer. And the big family is the BRCA or BRCA genes, which are also implicated in breast cancer, as many of you know. And again, I'm going to leave this for Dr. Cheng, but I'm going to just plant the seed because it's very important. They also, these guidelines then give some recommendation for treatment. And many patients come to me and they say, hey, Dr. Lin, can we do focal therapy or other novel therapies? But if they have high-risk disease, the guidelines are very clear. Clinicians should not recommend whole gland or focal ablation for patients with high-risk prostate cancer outside of a clinical trial. We at the University of Washington have HIFU. We have some other focal therapies. We have some trials as well. So outside of a clinical trial for high-risk prostate cancer, we don't do focal ablations or whole gland ablations. What about surveillance? And again, the guidelines are pretty clear. Like say statement 24, it's out of a big long list. Clinicians should not recommend active surveillance for patients with high-risk localized prostate cancer. Watchful waiting should only be considered in asymptomatic men with a limited life expectancy. So if a man is an otherwise healthy patient with high-risk prostate cancer, there's no room for active surveillance. So what is the recommendation? Well, the recommendation is here. Clinicians should recommend radical prostatectomy or radiation therapy plus hormonal therapy as standard options for patients with high-risk localized prostate cancer. And we're going to dive a little deeper into this. So what about surgery and radiation? Well, unfortunately, when we look at surgery and radiation, they have a fairly high risk of recurrence, at least 50% chance of recurrence after either just surgery alone or radiation with hormonal therapy alone. One of those two, unfortunately, there is a pretty high recurrence in high-risk prostate cancer. Testosterone suppression, so what we call ADT or hormonal suppression, improves radiation outcomes. So there have been many trials that looked at radiation alone versus radiation plus testosterone suppression, and the group that got both together did better every time. The addition of radiation after surgery might improve outcomes. So there is some evidence to that. But let's dive a little deeper into this. There was, and this is new data. So this is new since last year, since we spoke and met as a group. This is a very interesting a trial called the Stampede trial. It's been in existence for many years. But in this part of the trial, they did a very interesting a study where they took nearly 2,000 men. And they all had high-risk prostate cancer. And they all had pretty high risk. I mean, very high risk in some ways. They either had what we call T3 or T4. In other words, the rectal examination was abnormal, or they had to have a Gleason score of 8 to 10, or maybe even a PSA over 40. And I'm simplifying a little bit because there were some recurrent cancers in here, but mostly it was men walking in the door with these characteristics. And they all got radiation therapy, and they divided it either to radiation with standard testosterone suppression, or ADT, or they got radiation with standard testosterone suppression plus abiraterone. And there was a group that got the addition of enzalutamide. And again, we can get into that later maybe, but there was no doubt that when, at the end of the day, that there's a clear improvement in the rate of metastasis and the rate and better overall survival in men who had the addition of abiraterone to the standard testosterone suppression. So now that's become, in many ways, some of the standard of care. I can't mention radiation without at least talking about surgery a little bit. I'm a surgeon. I think there are some theoretical advantages to surgery in high-risk prostate cancer. Maybe we take out the source that can affect future spread of cancer. Unknown. There's a big trial called SWOG 1802 that's investigating that. Maybe we're selecting resistant cells in the prostate due to response to treatment. And again, that might influence future metastasis. And then, of course, there is the availability of radiation after surgery. If a man has surgery, they can still get radiation. The flip is not available. So there might be some theoretical advantages. Well, what do the guidelines say? Now, these are the National Comprehensive Cancer Network guidelines. These are kind of like the Bible for the treatment of prostate cancer, if you will. It's not according to Dan Lin or University of Washington or anybody here. It's the national guidelines. And I think it's instructive to look at that. For men with, again, high-risk prostate cancer, with a life expectancy, a reasonable life expectancy and health. Again, I said it before, some form of radiation or surgery. And they do note that radiation can be given with abiraterone for very high-risk disease, okay? But it's really radiation of some sort with hormonal therapy and maybe even abiraterone, or it's surgery first. And after surgery, then depending on what the pathology looks like, maybe the addition of radiation therapy or the addition of hormonal therapy. That is standard of care. Nowhere on this page do you see focal therapy, laser therapy, chemotherapy, anything like that. And so that is the standard of care for men newly diagnosed with high-risk localized prostate cancer, again, after a bone scanner and a CT or an MRI, or maybe now the new age after PSMA PET imaging. So I'm going to end with just a few things on the future directions and how to improve therapy, how to personalize therapy, because I think that's what our group here in the Pacific Northwest is all about, personalizing therapy. There have been multiple studies looking at chemotherapy. I mentioned the word chemotherapy the first time, just last slide, and we've looked at that, whether chemotherapy works. And I'm going to show you very quickly, this is a study that Bruce Montgomery and I led through the VA system, where we took men with high-risk prostate cancer. Then after surgery, half of them got chemotherapy and half of them didn't. The Swedish group and a Scandinavian group mostly did the same thing. After surgery, either get chemotherapy or nothing, and watch them and who did better. The radiation therapy group did it the very similar thing. They said, again, as I said, what's standard of care for very aggressive prostate cancer? Well, it's radiation with hormonal therapy, like ADT or of some sort. Well, they added chemotherapy to that and saw how it went. And then there's one final study where instead of doing it after surgery or during radiation, they did it before surgery. So doing it with neoadjuvant or before surgery chemotherapy, and then following that with prostatectomy. And I think the summary of all those chemotherapy trials, either before or after surgery, there's a slight improvement if chemotherapy is used after radiation, although I think that's awaiting pending further results. There's conflicting results in use after surgery, and there might be some advantage to using it before surgery. At the end of the day, it's not considered standard of care yet, either before or after surgery or radiation, which we've moved on from. There are multiple trials now that have been looking at the use of therapy before surgery. And this is one of them. This was Elihim Astagal, who wrote this paper up. She's one of our investigators here at University of Washington and at the Seattle VA. And it was in men with high-risk prostate cancer. and gave a variety of different ways of basically annihilating the hormones in the body, and then went to prostatectomy. And she reported on this. There was another study that was led by Bruce Montgomery and others that again took men with very high risk prostate cancer and then either gave them hormonal therapy alone, like Lupron, or with the addition of abiraterone. And then we took biopsies and then gave both groups both drugs and then did a prostatectomy. And that had some very interesting results. And then, of course, the next trials, which were again led by Bruce Montgomery and Marianne Taplin at Dana-Farber in Boston and others, took the same group of kind of people that had very aggressive prostate cancer and then gave them even more, gave them abiraterone plus enzalutamide or just enzalutamide, and again took the prostate out. And I think that after all those trials and hundreds of patients, we found that there was a major response in some men. I mean, some men went from a large volume tumor to almost little or no cancer left in the prostate, but it was deciding on who really responded the best is the issue. We also noted that more testosterone suppression, more response in the prostate. There's no doubt about that. And there might be some suggestion that men who went through these trials had decreased recurrence over long term. And again, I think this is still a work in progress. All these studies, I think, spawned a very major trial. It's over 1,500 men that have already done, that are already enrolled in this trial. And it's actually a different drug called apalutamide. And the design is interesting. I'll walk you through it. In men who are, again, high-risk prostate cancer, they get about 6 months of either standard hormonal therapy or with the addition of apalutamide, one of the two. And then they have a surgery, and then they actually get six more months of either of one or the other. And again, the decision is going to be whether more yields long-term, actually real metastasis-free survival. So I call that more real endpoints, as well as how it responds in the prostate. So stay tuned on this very important clinical trial. I'm going to end again with the last thing, and again highlights what we do here. I think we've taken just groups of men and given them therapies. Now we're doing genomic sequencing and matching agents to what patients have in their DNA or their tumors. Most of these defects are a small number of patients, and it makes these trials difficult. But now we have an opportunity to sequence all patients and find out which mutations they have. If they have an actual one, then we give them a drug that matches that. Heather Cheng, who's going to talk a little later today, and she'll talk about this, so I'm going to kind of leave it for her, I think. But these are a very interesting trial that was just through the approval process through the national group called SWOG. It's called SWOG 2210. She's the national leader of this. And it takes men who have high-risk prostate cancer with a mutation in BRCA1 or 2, and then they're going to get carboplatin chemotherapy followed by prostatectomy, and we're going to see how that works. It's going to be a smaller trial, very interesting. Mike Schweizer here locally is leading this trial along with Martin Gleave and others in British Columbia, of course. And this is called the GUNS trial. It's called Genomic Umbrella Neoadjuvant Trial. And again, this is taking men who have high-risk prostate cancer and then assigning them based on their what we call mutations or variations. If they have a variant in, let's say, P10, then they get the addition of stronger hormonal agents. If they have a variant in BRCA, they get what we call a PARP inhibitor. If they have a variant in their immunogenic signatures, then they get an immunotherapy. And so everybody gets assigned a different arm based on their genomics. A very interesting trial, and stay tuned on this one as well. So I'm going to end here. I thank you for your attention. Just some take-home points in the newly diagnosed high-risk prostate cancer. I think all standard therapies, unfortunately, have substantial recurrences. What's happened in the last year or two have been really consideration for first doing molecular imaging, PSMA PET, which you'll hear about later, as well as germline testing for mutations. Again, you'll hear about this later today from Dr. Cheng. The addition of abiraterone, fortunately, with radiation has yielded substantially improved outcomes. And that's now, I think, fast becoming standard of care for the very high risk prostate cancer patients. I say stay tuned because we have a wealth of trials. Again, many of them originating right here in the Pacific Northwest, certainly neoadjuvant trials, personalized therapies. I think all this will make the lives of our prostate cancer patients and their families much better. So again, I thank you for your attention, and thanks for coming to this conference, and look forward to your questions.
Good morning, everyone. It's a pleasure to be here with you today as part of the 22nd Annual Pacific Northwest Prostate Cancer Conference. Hello to those in Portland and in Seattle and wherever else you might be in the Pacific Northwest. My name is Heather Cheng. I am delighted to be here today. You can read my affiliations there. I'm going to spend the next 15 or 20 minutes or so talking about a topic that's near and dear to my heart, which is what you should know about the growing importance of genetic testing in prostate cancer. Okay, let me, here are my disclosures. All right, so I'm going to just start with what we talk about when we talk about genetics. Sometimes we mean different things and language is important. So for the purpose of this talk, I'm going to be referring to inherited DNA, or what we often call germline genetic testing, as essentially the master blueprints of what we inherit as our DNA, and which is comprised of each of us has unique DNA, and we get half of the material from each of our parents, our mother and our father. And in all cells of the body, these the same set of master blueprints exists, and certain gene variants or gene mutations are linked with a higher risk of cancer. And sometimes those are called cancer risk genes or cancer predisposition genes. And tests that we use to identify whether there is, in fact, one of these mutations or pathogenic or damaging mutations are blood tests, saliva tests, or skin tests. And what's important to know is that this DNA, the germline DNA, does not, by and large, change over time. The methods may change, but the fundamental kind of blueprints of what the master copy doesn't change over time. In contrast to this is kind of what we consider cancer-specific DNA. So, you know, this symposium is about prostate cancer, so let's use prostate cancer as an example. This can sometimes be referred to as genomic testing or somatic testing or biomarker testing. I'm going to come back to this in a moment. But essentially what this refers to is the working manual or the DNA that exists and is private to cancer cells. So cancer cells are healthy cells turned rogue, right? They stop behaving, they stop following directions, they cause trouble, and they no longer follow directions. But they start with the master blueprints, and then they pick up mistakes and errors. And these mutations that are private to the cancer are not passed on to children or shared with siblings or inherited from parents. And so in order to glean what's in cancer cells, we have to sample the cancer tissue. And often this is done by a biopsy. And in more and more, there's interest in trying to do this through the blood if there's enough cancer that we think might be getting in cancer cells in the blood cells, then we can sometimes infer this, or DNA from the cancer. So this is a really exciting area. And I'm not going to focus most of my talk on this, but other talks may. In this arena, test methods are evolving, and the tumor itself may also evolve. But just to go back today for the next, 15, 20 minutes, I'm going to be focused on inherited DNA testing or germline genetic testing. The cancer-specific testing is important, but we're going to start with the germline. Okay, so here's another way of thinking about it. I'm a visual person, so I like to kind of draw analogies. So the analogy of the master blueprints is the, Ford or Honda or Toyota. They have blueprints for their cars, right? Here's a number of different cars, and they're all pretty similar because they come from the same instruction manual, let's call it. And then there's cancer-specific DNA, which is like the working manual. So this is an image taken from Mad Max, but you can trick up your car as you would like, but that's not part of the master blueprints. That's private to that car, right? That's not something that would be, if you copied your playbook, you wouldn't get it in the master blueprints. It would be the working manual. So that's another way of sort of thinking about it. Just to sort of highlight to you, the terminology or the words that we use can be somewhat confusing. And so here's another way of thinking, another way of illustrating it. So genetic testing for inherited cancer risk as I said, also called germline mutations, inherited mutations, can also be called pathogenic or likely pathogenic variants. And they, again, refer to inherited cancer risk. And then biomarker testing is kind of the new, is what we're also using for tumor testing. So that previously was referred to as somatic testing or tumor specific mutations, acquired mutations, those that are not inherited. But I would say that if the purpose of biomarker testing is to determine what the treatment plan should be for precision oncology, which you'll hear more about today, is really exciting. Biomarker testing can also be germline mutations. And by that, I mean that even if you have an inherited mutation, that can lead to a new option for therapy. And that's, really exciting. And so just want to sort of bring that up. But this need for consistent terminology is something that we recognize, and it can be confusing. So I'm going to try to say it a number of different ways to hopefully drive that point in. Here's another way of thinking about it. So germline or inherited cancer risk genetic testing is intended to test for inherited cancer risk. However, there's also this overlap of biomarker testing. So in this middle of this Venn diagram, there are times when both of these overlap. And in the case of biomarker, the question is, what is the best treatment for me? Or can I learn more about the DNA of my cancer or myself that might lead to new options for treatment? And that's pretty exciting. And now we have this new intersection in the middle of both treatment decision-making and genetic counseling. And also, this is important because if there's an inherited component, then there may be risk to family members that they may want to know about and take advantage of and be proactive in managing that risk. Or an individual may have a risk of other cancers, and maybe we'd want to think about screening for other cancers differently. All right, so now we'll get into the prostate cancer, into the meat of it. This is prostate cancer disease states 101. This is kind of how I think about prostate cancer, starting from the left, which is early detection, or people who are at risk for prostate cancer who do not yet have prostate cancer. Maybe they have an inherited cancer risk mutation. Then people who have localized prostate cancer, it's only in the prostate, have options for active surveillance. Other people will be talking about that. Definitive treatment, which can include surgery to remove the prostate or radiation with or without hormone therapy. And that's ADT, androgen deprivation therapy. We also refer to as hormone therapy. And then I'm a medical oncologist, so a lot of what I think about is in this advanced disease state where people may have a rising PSA, and they may respond to testosterone suppression or ADT or not. And so that gives us a number of additional disease bins, which I'm not going to go into in detail, but you can see they include biochemical recurrence, metastatic castration, sensitive prostate cancer, non-metastatic castration resistant prostate cancer, and metastatic castration resistant prostate cancer. And they're broken up into basically, does ADT control it or not? Yes, no. And then can you see it on a scan or not? Yes, no. And I think we'll have heard some of our other esteemed speakers today talk about these disease states, each of which have exciting new kind of treatment options. So it's really exciting days in prostate cancer. Okay, so precision treatment opportunities in advanced prostate cancer. This is kind of one of the things I get very excited about. So we know from work that's now a few years old now that over 20% of patients who have metastatic prostate cancer in their cancers, they have certain mutations in genes that are important in repairing DNA. And these are also known as homologous recombination DNA repair genes, BRCA2, BRCA1, ATM, and others. And these defects or mutations are potential or are known now treatment biomarkers for response to a new class of drugs called PARP inhibitors that have been recently FDA approved, as well as platinum chemotherapy. So this is really exciting. And about half of these people, so 10% of men with metastatic prostate cancer, have this DNA repair gene defect as an inherited component. And so this is an opportunity to, do germline genetic testing for inherited cancer risk and also potentially provide life-saving valuable information to relatives if we have this, and also treatment options if they're there. So again, 1 in 10 men with metastatic prostate cancer carries the germline or inherited mutation in a DNA repair gene. In this first study by Pritchard et al. In 2016 in the New England Journal of Medicine, we found that it was almost 12% actually. It varies depending on the patient population, but what's really important is some of these men did not have a family history of prostate cancer or other cancers. And so that's often, what we think of to sort of lead to suspicion for genetic testing is, oh, is there a family history of cancer? These men did not necessarily have a family history of prostate or other cancers. And the presence of these mutations in the inherited or germline DNA, the fundamental DNA, represents a known, or in some cases, suspected cancer predisposition syndrome. So these are genes I'm going to talk about a little bit more. You've probably heard, some of you may have heard of them, BRCA2, BRCA1, CHEK2, ATM are a little less well known, but these are genes that are in BRCA1 and 2 certainly are associated with cancer predisposition. So important to know about. And then the prevalence estimates looking at these genes is pretty high. So 5% of men with metastatic prostate cancer have BRCA2 mutations. 1% of men have, this is metastatic patient or advanced prostate cancer. They're not huge numbers. That's not the majority of people, but it is an important group because there is a lot of potential benefit, and we're also learning a lot about the biology. So it may also be enriched in patients and men in families who have breast cancer and ovarian cancer or pancreatic cancer. And then there is another class of genes, MSH2 and MSH6, which is present in about 1.5% of men with advanced prostate cancer, and they may have family history of colon and endometrial cancer, or they have high Gleason grade. And so this is something, and we're still learning about the prevalence across disease states. And by that, I mean, is it metastatic? And I just told you it was 12%. Is it another series said 16%? So again, it depends a little bit on the population. This is a Spanish study. So in the Spanish population, there may be slightly different percentages. In the metastatic hormone sensitive setting, about 9.4, 9.5. And in the high-risk localized disease setting, about 9.5 or so. And so we're still sort of learning about this, but it is an important population and it does confer options for treatment. So here's another way of looking at DNA repair defects in prostate cancer, homologous recombination, and then another family of genes called mismatch repair, and that's the MSH2 and MLH1, and then the BRCA1 and 2 are here. And these are all important gene families that are really critical for maintaining the quality of the DNA. So every time cells divide, it's really important that the DNA be copied with as much accuracy as possible and that mistakes don't get introduced. But when mistakes get introduced into the family of genes that actually is responsible for error correction, then more mistakes can then continue to happen. And so again, 12% with metastatic prostate cancer, and this represents hereditary breast and ovarian cancer syndrome, also referred to as King syndrome, and then 20% with Lynch syndrome or genes involved in mismatch repair, MSI high as another way of looking for that. So and then again, the importance of this from an advanced disease standpoint is that there are now PARP inhibitors, 2 PARP inhibitors, rucaparib and olaparib, and a platinum chemotherapy that are felt to be and known to be especially effective in men who may have these mutations. And if there's this class of mutations, then we believe that immune checkpoint inhibitors may also be an option and particularly effective in men whose cancers have these features. So here's sort of another illustration of this, the expanding systemic treatment options. This is the sort of toolbox for everyone, unselected for mutations. And now, we have ADT, abiraterone, enzalutamide, docetaxel, apalutamide, sapilizumab, cabazitaxel, radium-223, darolutamide, and new on the block is Pluvicto. Also very exciting. You'll hear more about that drug. And then there's a special toolbox for people whose cancers have specific mutations or biomarkers, pembrolizumab, rucaparib, olaparib, and carboplatin. So really, really exciting. And so trying to find out if a patient is a candidate for the special toolbox may involve genetic testing. All right. So who should be offered genetic testing? And again, this is referring to germline genetic testing. So these are the National Comprehensive Cancer Network guidelines, and it's a busy slide, but really I'm going to break it down to people who have a personal history. They themselves have metastatic prostate cancer, very high risk prostate cancer that's still in the prostate. So Gleason 8, 9, or 10, PSA over 20, a family history of a known mutation in a gene such as BRCA2 or a Lynch syndrome gene, a strong family history of cancers, including breast cancer, colon cancer, pancreatic cancer, ovarian cancer, GI cancers, people who have Ashkenazi Jewish ancestry, people who may have a history of male breast cancer. If you're not sure, share what you know with your doctor. They can help you navigate, if you meet criteria. And then there are other people who we consider in, those are intermediate risk prostate cancer with the presence of intraductal or cribriform histology, because those histologies on your biopsy or in your prostatectomy have been associated with an increased likelihood of having mutation. And actually, much of the work of that has been led by people from our institutions. So pretty exciting. Having a personal history of multiple cancers, maybe somebody had colon cancer and melanoma and prostate cancer. Those are things that might lead us to be more suspicious. So a few words about inherited BRCA2 mutations. We know that it increases presence of a BRCA2 mutation, increases the risk of developing prostate cancer by about 5 to 9-fold. Other cancers as well, such as male breast cancer and sometimes pancreatic cancer. These cancers are more associated with more aggressive disease and worse prostate cancer outcomes. They're also enriched in metastatic disease, as I mentioned earlier. But I believe that even though that's true, if we look for patients with BRCA2 moving forward, if we're able to be proactive, if we know this tendency in advance, if we can understand the weakness of the cancer, then we can tailor the management. So at present, we might be able to tailor screening and early detection for prostate cancer. We can design new strategies to improve the chances of cure. And then we can incorporate and add precision therapies to the therapy toolbox earlier in an effort to improve the outcome. So I envision dramatically improved outcomes if we can really know this early and leverage this information so patients have better outcomes. A few words on the fact that genetic effects on cancer risk and treatment response are not equal. Just a few, I just talked about BRCA2. This is relatively rare in the population. If the risk of developing prostate cancer is estimated to be around 60% by the age of 85. And if prostate cancer developed, it's worse outcomes, as I mentioned. And it occurs in, depending on the population, 1 in 400 people, or if you're Ashkenazi Jewish ancestry, it'd be 1 in 50 people. And then there's also something called polygenic risk scores, which we're getting excited about learning more about. And I would say is still not quite prime time, but does refer to germline genetics. And we're working very closely with our colleagues, Dr. Sokolova and Dr. Darst and others on understanding the interplay between polygenic risk score and rare variants such as BRCA2. So this is just to say, there are some genes like BRCA2 that change the risk a substantial amount by themselves, like an entire flight of stairs, and others that change the risk by a flight or two, a step or two up. And so we add them all together and maybe we get a total lifetime score. But at present, the testing that we do is really focused on the rare variants, these genes that we know might really change the risk by quite a bit. And then we're filling in the gaps for the less well-studied genes. And so there are genes such as ATM, CHEK2, which we know are mutated more in advanced prostate cancer. They may increase the risk of developing prostate cancer. We're still learning about how they predict response to some of our new treatments like PARP inhibitors and other drugs. And we're really interested in new drugs, new combination strategies, and understanding, are they more effective earlier or possibly not? And so that brings me to a registry for those of you who may have already undergone germline genetic testing or who have not done so and are interested in it. There's a PROMISE study, which is a registry. And by that, it's web-based, it's phone-based, and you can participate by providing a saliva sample, getting your germline genetic testing results, and then if you have a variant of interest, we follow long-term outcomes to try to answer these questions of, do people respond better, worse, which treatments might be better, and then also let you know about clinical trials. Here's a word on cascade testing. So one of the things I think about a lot, and in genetics, we think a lot about, is if, let's say, this is a group of 10 men with advanced prostate cancer, high risk or metastatic prostate cancer, we know 1 in 10 of those men has an inherited cancer risk mutation in a DNA repair gene. By definition, that man, if he has any siblings, his siblings will also have a 50% chance of carrying the same risk mutation, and his children may also have a 50% chance of inheriting or have inherited that. And so if we can be proactive and do what we call cascade genetic testing, which is testing family members, relatives who don't yet have cancer may have life-saving options for early detection and or risk reduction. So this is really important, especially for, we're more mature with this in breast and ovarian cancer, but if there is a BRCA1 or BRCA2 mutation, we at the Fred Hutchinson Cancer Center, and then also at Oregon, OHSU, there are things that can be done to reduce the risk. There are cancer risk clinics. Dr. Sokolova, myself, and many of our colleagues can put you in the right direction. So definitely be thinking about this if you're one of the people who might have one of these mutations. Really important to know about, and for those who want to know, to be proactive. Currently, the FDA approval for targeted therapies are in the sort of advanced disease to date. I just want to very briefly mention there are clinical trials now in the sort of middle states as well, and others may talk to you about that, or if you're interested, you can ask your doctor about it. Talked a little bit about cascade testing. Just in the interest of time, I just want to emphasize again tailored screening and risk reduction and finding cancer early. Just a quick shout out to a study called Patrol, which is being led both at the University of Washington with a colleague of mine, Dr. Daniel Lin, who's a urologist, as well as Dr. Sokolova and her colleagues at OHSU. And this is really for men who might have a cancer risk mutation like BRCA2, like HOXB13, like some of the others, and a way to be more proactive. If you think you have an increased risk of cancer, can you do more to find the cancer early to improve the overall outcome? And we hope the answer is yes. Here's the NCCN guidelines currently for 2022, saying that who is at risk for prostate cancer. The people who are at increased risk of prostate cancer should start screening earlier. And who are those men? Those are people who are Black and African American, because we know that's a higher risk of developing prostate cancer. Men who have germline mutations, those inherited mutations I talked about that increase the risk for prostate cancer, and those who have a really strong family history of cancer, including prostate, but other cancers. If you're not sure, again, talk to your doctor about the specifics. Here's the information about Patrol. I won't spend much time talking about this, but definitely ask if you're interested. It's open at the University of Washington and soon to open at OHSU and hopefully open at other places as well. And then also for other men who might live on the East Coast, this is the MCI study, men at high genetic risk for prostate cancer, and sort of contact information there. I'm not going to talk about biomarkers. I think that's going to be covered in another talk. And so I'll end with my take-home points. Genetic testing, inherited genetic testing, and biomarker testing are increasingly important in prostate cancer care. I hope I've convinced you of that today. Rapid changes in how gene mutations, inherited and tumor-specific, affect treatment decisions and options. So this is really exciting, but definitely talk to your doctor about this and ask about it in order to sort of gain maximum knowledge. Ongoing clinical trials of treatments are available for men with mutations in their prostate cancer, either with or without cancer, or screening for those who may be at risk for prostate cancer. So we always encourage you to ask about that, and hopefully some of you will be interested in participating in some of these opportunities. They're really exciting. Ongoing trials offer men genetic testing and counseling. So Promise is one of them. Check it out if you're interested, and also long-term follow-up for people who have mutations. We're really interested in partnering with patients to learn more faster. Talk with your provider, seek guidance at centers of excellence, get a second opinion. OHSU here at the University of Washington and Fred Hutch, we'd be happy to see you and talk more about these details if you're interested. It's exciting time. So with that, I'll wrap up. Thank you so much for your attention.
Hello, my name is Jaqueline Vuky. I'm a medical oncologist at the Knight Cancer Institute, and I'll be discussing treatment options for metastatic prostate cancer. These are my disclosures. So treatment options for metastatic prostate cancer is fairly broad. So we're going to focus on what is new and what is important, and splitting those into two states within the metastatic space. The first is what we consider metastatic hormone naive, also known as hormone sensitive. And we'll be discussing how combination therapy has clearly established to improve overall survival. And by that, we mean the addition of androgen deprivation therapy with one of these other treatment options, whether they're chemotherapy or one of the novel hormonal agents listed here, abiraterone, enzalutamide or apalutamide, and also the role of triplet therapy, particularly in patients who have what we consider high volume disease. We'll then turn our attention to metastatic castrate-resistant disease, the multiple treatment options that are currently available, how patient selection, or rather treatment selection, is driven by both the disease characteristics and prior treatment, as well as some patient comorbidities. We'll touch on some new developments with PARP inhibitors and the radioligand lutetium-177 PSMA. So this is what we're going to be discussing. So I always like to show this slide because we do refer to patients with the staging 1 through 4, which is fairly, predominant in other malignancies, and I think much more helpful in those to describe the other malignancies such as breast cancer and lung cancer. But in prostate cancer, for several decades now, we find this disease state model very helpful in terms of thinking about how patients, which sort of disease state patients are in, and how that progression occurs. So majority of patients are diagnosed with localized disease and are stratified into low, intermediate, and high risk. And we've heard discussions about the different treatment options within localized disease. Patients can then move to biochemical recurrence if they have a rising PSA. And then Dr. Graff has discussed how to sort of treat in that space. I'm going to be focusing on when patients present with metastatic disease, both in hormone sensitive, and you can see that patients can enter the space straight from localized disease, or even what we consider de novo. So we don't even have the diagnosis of localized disease, and patients, their first presentation is already with metastasis, or if patients have already been treated in a biochemical recurrence setting. And once patients have been treated either with an androgen deprivation therapy and progress, they enter the metastatic castrate-resistant prostate cancer space. And L stands for the line of therapy. So you can see that there are multiple lines of therapy that patients can have treatment with. So metastatic hormone-sensitive prostate cancer, what is the definition? So usually the testosterone level is in the normal or non-castrate level. This just refers to more than 50 nanograms per deciliter, but clearly usually that number is much higher, but that's our cutoff is 50. Patients will have metastatic disease, which refers to, excuse me, the fact that the cancer is spread to the bones, the liver, the lung, and the lymph nodes, usually outside the prostate. And then just like with localized disease, we do assess the extent of disease, and we determine if patients are high volume or low volume. So an example of the extent of disease evaluation is on this slide here. So to your left is a bone scan, and you can see that within this skeleton, there are multiple areas of uptake, which is demonstrated in the areas of black, and that represents disease, metastatic prostate cancer to the bone. And when we think about high volume disease, our usual definition is 5 or more bone lesions, of which one is at least outside the vertebrae or pelvis. So this patient also has uptake or metastasis in the distal skeleton. So the femur, for instance, also in the skull, and also the ribs. To the right is a cut of a CAT scan through the liver, and the gray area is normal. And you can see that there are darkened nodules within that liver, demonstrating involvement of the liver with metastatic prostate cancer, and that's considered also high risk with visceral metastasis. So how do we treat metastatic hormone-sensitive prostate cancer? So androgen deprivation therapy is clearly the basis of the treatment, but what about adding other therapies, and can we improve overall outcomes, specifically longevity? And so the answer is yes, and these are the trials that have demonstrated the addition of chemotherapy in both the CHARTED and one of the arms of the STAMPEDE trial. So when we add chemotherapy with docetaxel for 6 cycles with androgen deprivation therapy, we do improve overall survival. So that 0.61 is a hazard ratio. So that represents a 39% risk reduction in risk of death for the patients who receive docetaxel and androgen deprivation therapy, combination therapy, compared to what we call ADT monotherapy. What does that mean? So overall, there was about a 13.6 month improvement in longevity in the overall population. When we look at just the high volume population, it was 17 months improvement compared to just monotherapy. What about adding the novel hormonal agents, abiraterone, enzalutamide, or apalutamide? So all those agents also have demonstrated, you can see they're very similar hazard ratios with over almost a 40%, so a 38% or a 30% reduction in death with combination abiraterone and androgen deprivation therapy. Enzalutamide, apalutamide also with very similar hazard ratios. So they're really standard of care in patients who present with metastatic prostate cancer and have not received androgen or currently not on androgen deprivation therapy and are considered hormone sensitive. Combination therapy is recommended. There's exceptions in terms of if the patient can't tolerate, and sometimes there's cost considerations, and we do have to think about high volume or low volume disease. And in general, the novel hormonal agents, either abiraterone, apalutamide, or abiraterone is usually combined, and in high volume, we consider adding docetaxel. So specifically in high volume patients who have a poor prognosis, particularly if patients present de novo with high volume disease, there have been trials which have compared androgen deprivation therapy and the chemotherapy docetaxel with a novel hormonal agents. As you can imagine, there are more side effects, but the question that we posed in these clinical trials was, would it improve overall survival compared to just docetaxel and androgen deprivation therapy alone? So recently, 2 trials have been reported. This was the Arisons trial, which evaluated darolutamide with docetaxel and androgen deprivation therapy compared to docetaxel and androgen deprivation therapy, published by Smith et al. In the New England Journal of Medicine, and this demonstrated a survival benefit. So this is an overall survival curve demonstrating darolutamide on the upper curve and no darolutamide, we call that placebo, in the lower. Although placebo does not mean placebo, patients did receive docetaxel and androgen deprivation therapy. The median survival has not been reached with the darolutamide, the triplet arm, and was 48.9 months with the ADT and docetaxel arm. In the secondary endpoints of time to castration-resistant prostate cancer, darolutamide also improved outcome with the median time to castrate-resistant prostate cancer not reached, and it was 19.1 months for the no darolutamide arm. Time to pain progression also showed improvement, not reached with the darolutamide arm, and 27.5 months for the no darolutamide arm. The PEACE-1 trial was a very similar design trial with the novel hormonal agent abiraterone, docetaxel, and androgen deprivation therapy also demonstrating improvement, particularly if you notice on the curve or the survival curve F, which is ADT with docetaxel population in high volume metastatic burden, which demonstrated a hazard ratio of 0.72 and did not really demonstrate benefit in the low volume population. There have been a couple of criticisms about this trial because the comparison arm in both studies included docetaxel as opposed to comparing it to a novel hormonal agent. But this is the data we have, and so again, triplet therapy improves outcomes in high risk, high volume hormone naive prostate cancer patients. Turning our attention now to metastatic castrate-resistant disease, this table outlines the treatments that have been approved since 2004 for metastatic castrate-resistant prostate cancer. So docetaxel was approved 2004, Sipuleucel-T, which is a dendritic cell vaccine, approved in 2010, really indicated for highly selected patients who have mostly bone disease but are asymptomatic or very minimally symptomatic. Cabazitaxel, which is very similar, it's a chemotherapy to docetaxel, considered a cousin drug, demonstrated benefit in treatment after docetaxel. The novel hormonal agents, abiraterone. Abiraterone inhibits a key enzymatic pathway to androgen production, both in the prostate cells, cancer cells, as well as the adrenal glands and the testicle. Enzalutamide is an androgen receptor inhibitor. Both have demonstrated survival benefit in a hormone-resistant setting, and obviously, as you can see, in the hormone-sensitive setting also. Radium-223 is a radioligand. Radium is an alpha particle emitter. Radium is very similar to calcium, where it does get fairly well absorbed in the bone. And it's very useful for patients who have symptomatic bone-predominant metastatic castrate-resistant prostate cancer and did demonstrate an overall survival benefit. And lutetium-177, which we'll discuss in a little bit, which is also a radioligand that recently garnered approval this year. So how do we sequence patients in castrate-resistant prostate cancer? So you can see that many patients have already received one of the novel hormonal agents or even chemotherapy in the metastatic castrate-sensitive setting. So, patients can have what we consider different performance status, how fit patients are, and then how healthy they are if they have already other health issues that might limit our treatment, such as a history of heart disease, or diabetes, or neuropathy in their from prior treatments. All this, or how long patients have responded to a novel hormonal agent, how long the disease has been treated, and how long even since the last chemotherapy. It all plays into how we sequence the next treatments. So one approach would be considering Sipuleucel-T in well-selected patients, trying one of the novel hormonal agents if a patient has not had one of them before, re-challenging with docetaxel or introducing docetaxel if patients haven't had it, re-challenging again with one of the novel hormonal agents, considering lutetium-177, particularly if patients have uptake on a PSMA PET scan. Cabazitaxel, we can argue, could be even before the lutetium, and then considering radium-223 treatment, particularly if patients have symptomatic bone disease. So next I'll discuss the PARP inhibitors, which is currently approved in a very specific space, which is in patients who have one of these genes that are associated with with DNA repair defects, also called homologous recombination repair. So this paper was published from the New England Journal of Medicine back in 2016, really alerting us to the fact that germline mutations were much more common than what we thought in our prostate cancer population, particularly in our high risk and recurrent or metastatic patients. You can see on this pie graph that BRCA2 is the most common of these HRR mutations, with ATM, BRCA2, and BRCA1 being less common, but a host of other genes that are listed here. So this was published in 2015 with one of the PARP inhibitor drugs. So olaparib is a PARP inhibitor. And what these PARP drugs do as a class is they block the repair of DNA single-strand breaks and can lead to cell death in patients with these homologous recombination repair. So if you can't repair your DNA, either because you've already had a defect, and we introduce a drug that also blocks the DNA repair process, this leads to what we call lethality. So this was fairly exciting. So in patients who did have one of the biomarker positives, so one of these HRR mutations, there was an overall benefit with a median survival of 13.8 months compared to 7.5 in patients who did not have these mutations. In 2019, a PROFOUND trial was published with olaparib. This is also known as Lynparza, again demonstrating an overall benefit, particularly in patients who do have the one of these HRR mutations, particularly if they're BRCA2. So patients who have BRCA2 respond the best with regard to within the HRR mutations. So in conclusion, there are two agents currently approved. I didn't show the trials for rucaparib, but rucaparib and olaparib are approved. The indications are a little bit different depending on the HRR mutations, but again, in general, if in about 20% of patients may harbor a qualifying mutation, so we are evaluating both germline as well as somatic mutations, because half of these are inherited and can be detected in the blood, and half are cancer-specific, what we call somatic mutations, and can be detected both in the blood as well as the tumor itself. BRCA2 stands out as the mutation that is associated with the best response. There are some long-term side effects which we should be aware of, including rare risk of myelodysplastic syndrome and leukemia. Lastly, I'll discuss the VISION trial, which is targeting PSMA, which has garnered a lot of excitement. So PSMA is a cell membrane, stands for prostate-specific membrane antigen. It's highly expressed on the surface of prostate cancer cells. And if we can link it to a radioisotope, and this is lutetium-177, which is a beta particle emitter, we have a new therapy. So this trial, the VISION trial, was published in the New England Journal of Medicine last year. We participated, and one of the top occurs, Dr. Baer, one of my colleagues, is one of the co-authors on this. And this is the schematic of the trial. So patients with metastatic castrate-resistant prostate cancer were enrolled they had to have multiple prior therapies, but at least had to have at least one new androgen receptor pathway inhibitor, usually abiraterone or enzalutamide, and at least one, and could be allowed 2 chemotherapy regimens, and that's what we mean by taxane regimens. Patients were randomized in a 2-to-1 fashion to lutetium-177 along with standard of care. The standard of care excluded chemotherapy, immunotherapy, radium-223, or other investigational drugs because we didn't know how we can combine it with lutetium. So usually most patients received enzalutamide or abiraterone versus protocol permitted standard of care, and then were evaluated every 8 weeks during treatment, 12 weeks afterwards. And this was reported and garnered a lot of excitement, and demonstrated a 38% reduction in death and a 60% reduction in risk of progression. And clearly this was for patients who have uptake in PSMA PET scan, which I didn't mention. So with that, I'll end, and I look forward to discussing these treatments with all of you during the Q&A session.
Hi, so thanks again for joining us. So today I get to talk about some new approaches for the treatment of metastatic prostate cancer, and I want to talk about some exciting research that's going on across the field. There's a lot of work that's happening currently, and so I have to sort of hone this down and focus on just a few topics. So today I want to talk about some work we've been involved with testing new sort of paradoxical form of treatment for prostate cancer called bipolar androgen therapy, which involves using testosterone to actually treat the prostate cancer. Discuss some immunotherapy strategies for prostate cancer, and then also discuss a little bit of data regarding sort of refining biomarkers for selecting patients who might respond best to PARP inhibitors like olaparib, and also how to expand the use of these agents through combination therapy. Okay, so diving right in. So before we talk about some of these new approaches we're developing, I think it's important to understand some of the biology behind prostate cancer, because it helps us understand why we're actually developing some of the approaches that we're developing. So when we think about prostate cancer biology, one of the fundamental things that people need to understand is that the androgen receptor is really integral to the cancer survival. This is basically a receptor inside of the nucleus, inside of the cytoplasm of the cancer cell that binds to androgens like testosterone. And what happens essentially is that when this cancer cell encounters testosterone in your bloodstream, the testosterone molecule migrates into the cell, binds with the androgen receptor, and this whole complex migrates into the nucleus of the cell where the DNA is. And once it binds that DNA, it triggers a whole bunch of things to happen, including signals that tell the cancer cell to grow and proliferate and spread and do bad things. And so the name of the game in prostate cancer historically has been preventing this process from happening. We do this through a lot of ways. We can decrease the amount of testosterone in your bloodstream with androgen deprivation therapy, drugs like Lupron. We can decrease it even further by adding additional drugs like abiraterone, which really decrease the amount of testosterone in the circulation. Or we can use drugs that block the ability of androgens like testosterone to bind the receptor. And these can be done with drugs like enzalutamide, apalutamide, or darolutamide. But the theme here is all consistent. We're trying to prevent androgen receptor from driving cancer's growth. And so this all works really well, but one of the big problems that arises is that in spite of our best efforts, the cancer cells eventually learn how to work around this process. And one of the key sort of findings that we've discovered as a community is that after being treated with these drugs that target androgen receptor signaling for a long, long time, you begin to see that the amount of androgen receptor can increase as a response to having no testosterone around. And this is a compensatory mechanism. The cancer cell adapts as a way to try to grow in spite of our best efforts at suppressing it through these mechanisms. But one thing that's been shown in multiple different labs is that when you take cancer cells with high amounts of androgen receptor, sort of mimicking this resistant state, and you rapidly transition them from low testosterone levels to high testosterone levels, a lot of those cancer cells actually die. So there's kind of this paradoxical double-edged sword where when you expose them to the high levels of testosterone, you can actually induce a therapeutic effect. And so we translated this into the clinic in the form of something we've called bipolar androgen therapy. Essentially, in patients who are maintained on their androgen deprivation therapy, we treat them with injections of high doses of testosterone once every 28 days. And what this does is it results in really rapid spikes in testosterone from low levels to really, really high levels over a short course, which then begin to fall over the next month. And by the time that 28 days is up, the testosterone levels are relatively low, and we give them another injection. And so you get these sort of rapid spikes in testosterone, which, kind of confuses the cancer cell because it doesn't know whether it needs to learn how to survive in a low testosterone or high testosterone environment. And again, this has been something that has been shown in those preclinical studies to result in a good therapeutic effect in some settings. And so there's been several studies that have looked at this in the clinic. I just wanted to briefly touch upon the Transformer trial, because this is the biggest trial that's tested bipolar androgen therapy, or BAT, in patients with castration-resistant prostate cancer. And so the key patient population that were eligible for the study were those with, again, resistant prostate cancer that had already also progressed on the drug abiraterone. And following enrollment, patients were randomized between either getting BAT alone or enzalutamide. The enzalutamide, as we know, when it's given after abiraterone, doesn't work that well, and this is because they're both hormonal drugs. And so we see a lot of cross-resistance between these agents. And the primary goal of the study was really to look at whether or not this could increase the amount of time until the cancer started to grow again on scans, which we call progression-free survival. And so looking at the outcomes on this study, we saw that between patients that got BAT versus enzalutamide, the outcomes were relatively similar, actually. So this is a figure that we refer to as a waterfall plot. Each vertical line represents one patient on the study, and the blue lines are those who got BAT, and the red are those who got enzalutamide. And when the line goes down, that shows the PSA relative drop. And so lines going down is good. It means that the PSA has decreased. What we saw was that 28% of patients getting BAT had a PSA drop of 50% or more, whereas enzalutamide had a PSA drop of 25% or more, which was relatively similar. Likewise, when we looked at time to progression, we can see that there was relatively similar outcomes too. This type of figure is called a Kaplan-Meier curve. And essentially on the left-hand side of it is when patients initially enroll, and then as the lines go down, that signifies patients showing evidence of disease progression while on study. And so you can see the red line, which is enzalutamide, and the blue line, which is BAT, look pretty similar in terms of the overall course of time to progression. And ultimately, we found that the median time to progression was 5.6 months with BAT and 5.7 months with enzalutamide. Again, really similar. But one other sort of key aspect of this study that really was interesting to us is whether or not BAT could actually counteract some of these resistance mechanisms that allow cancers to grow on these hormonal therapies. And to look at this, we allowed patients who initially got enzalutamide to go on to get BAT, and more importantly, patients that got BAT to go on to enzalutamide subsequently. And the idea was that we wanted to see whether or not giving BAT immediately after abiraterone could combat these resistance mechanisms and downstream allow patients to respond well to enzalutamide. And we actually saw just that. And so the patients who got BAT followed by enzalutamide did really well on the enzalutamide. So on the left here, this waterfall plot is looking at patients who got BAT enzalutamide in the red and enzalutamide BAT in the blue. And this is specifically looking at the responses to the second drug received. And I think I would just point out that the enzalutamide group had a PSA response rate of 78%, which is dramatically higher than the 25% we saw when patients immediately went to enzalutamide. And so it kind of supports the idea that BAT was suppressing those resistance mechanisms. On the right here, and I think more importantly, you also see that patients who got the combination of BAT than enzalutamide had longer progression-free survival. The time until the cancer grew took longer with that sequence at an average of 28.2 months versus only 19.6 months with the other sequence. And so it kind of supports the idea that giving BAT as a way to sort of sensitize or prime patients to respond well to downstream hormonal therapies may be a winning strategy. And trials are being designed right now and open to look at this question more explicitly. But I think this is sort of an important niche that, warrants further investigation. And hopefully BAT will be something that we can sort of begin to start using more standard of care, as currently it is still an experimental regimen. All right, switching gears, I wanted to talk about some exciting new things that are happening in the world of immunotherapy for prostate cancers. So the way I sort of think about the immune system is that its fundamental job is really to recognize things that don't belong in our body and try to get rid of them. And we usually think of this as being bacteria, viruses, things like that, but cancer also doesn't belong in our body. It looks distinctly different than a normal cell, and your immune system should be able to recognize this as not being something that should belong in your body and clear it. And so if you imagine you've got a nice, normal, healthy cell, your immune system sees this and says, hey, you look just like me, I'm going to leave you alone. But what happens is this cell can undergo mutations, and this can lead to the cell sort of becoming deranged and abnormal. And all of sort of the normal cell surface proteins that you typically expect in this normal healthy cell also become deranged and abnormal. And this leads to sort of the opportunity for the immune system to recognize this guy as being a bad actor and to hopefully attack him. And so when we think about how the immune system does this, the primary sort of workhorse of the immune system in terms of clearing cancers is the T cell. And what happens is when this T cell on the top here encounters a cancer cell on the bottom, what happens is that the cancer cell has some of these abnormal proteins on its surface. And the T cell should be able to recognize this and flip on and attack and kill the cell. This is what should normally happen. But in many cases, the cancer cell has come up with sort of strategies to avoid being cleared by a T cell. Specifically, in addition to this initial recognition signal that the T cell and the cancer cell have with each other, there are a bunch of other receptors which essentially act as off switches for the T cell. And the cancer cell has figured out how to turn these off. And so the cancer cell can flip these off switches. And this results in the T cell basically going to sleep and not doing its job. Importantly, we've developed drugs now which are able to flip these off switches back on again. So what they do is they basically block the off signal and allows the T cell to wake back up, say, hey, cancer cell's there, I'm going to attack it and kill it. And I've listed just several of the drugs which we currently use across a spectrum of many, many different types of cancer for this purpose. I would say that so far, these drugs, which we classify as immune checkpoint inhibitors, have been really effective in many, many cancers. I would say that the data for diseases like melanoma, renal cell cancer are really spectacular. And these drugs probably actually cure a subset of patients with otherwise really advanced cancer. So they've been a huge advance in the treatment of cancers in general. But so far, the data for using these drugs in patients with prostate cancer is pretty unimpressive, unfortunately. This is just data from one of the bigger trials testing a drug called pembrolizumab, which is another one of these immune checkpoint inhibitors that's used in a lot of different settings. And essentially what they found here was that only about 10% of patients on this study had a decline in their PSA, and radiographic responses, tumors actually shrinking on scans, was even lower. And so it really sort of led us to feel that as a community that these immune checkpoint inhibitors by themselves really aren't that effective for prostate cancer, and really sort of led people to start looking at sort of new ways, novel ways to try to stimulate the immune system better to try to get a good therapeutic effect. One sort of reason why this might be the case is that when we look across the spectrum of different cancers, we can see that prostate cancer tends to be relatively not as mutated as some of the other cancers that we treat. For whatever reason, when you look at a prostate cancer cell and you sort of quantify how many mutations are present, you don't see quite as many of them. And consequently, that means that you're not going to get as many tumor-associated proteins that look really abnormal on the cancer cell surface. And so the immune system is probably just not able to recognize that cancer cell as being abnormal enough to actually fight it. Conversely, if you look at some of the cancers on the far right-hand side of this figure, these are the ones that are really heavily mutated. And like I mentioned earlier, melanoma is kind of the poster child for responding well to these immune checkpoint inhibitors. That's one of the most heavily mutated cancers there, and it's on the very far right of this figure. And so this is probably one of the reasons why prostate cancer doesn't respond that well to these drugs by itself, although there's likely other more complex things going on too. I will just point out that there is a subset of probably around 5% of prostate cancer patients who have tumors that have actually really, really heavily mutated cancers. And this is because they've got sort of underlying inability to repair sort of DNA damage as it occurs and maintain genomic fidelity. And this leads to essentially to, over the course of the cell's lifespan, to accumulate lots and lots of mutations, orders of magnitude more than you normally see. And within this subset, they actually do exquisitely well when treated with these immune checkpoint inhibitors. This is just some data from our center looking at the responses in sort of these patients with this sort of molecular phenotype and looking at how they respond to these immune checkpoint inhibitors. The left here, again, is a waterfall plot looking at PSA responses. And you can see that the majority of guys with these hypermutated cancers do really well with these immune checkpoint inhibitors, and you see dramatic declines in their PSA. Likewise, on the right is time to progression for patients with these really high mutated cancers treated with immune checkpoint inhibitors. And you can see that following them out to 20 months or more, you're still not seeing the vast majority of them continue to respond quite well. And so, if you do have this genetic sort of subset of prostate cancer, this is sort of a setting where these immune checkpoint inhibitors work quite well. But, unfortunately for, the majority of patients, this isn't good enough by itself. And so this is, again, really prompted the field to move towards developing more effective strategies. And so I wanted to touch upon sort of two sort of things that are happening right now that are looking at developing more effective immunotherapy approaches for many cancers, prostate cancer included. One is something we call a T-cell engager or a bispecific T-cell engager, sometimes abbreviated as a BiTE therapy. And essentially what this does is this is a molecule that is able to bind both the T-cell as well as the cancer cell. And so what this molecule does is it basically forces an interaction between the T-cell and the cancer cell, brings them together with the idea that this is going to stimulate the T-cells to start expanding, so there's more of them to fight the cancer, and also force the T-cell to hopefully recognize that there's a cancer cell right at its footstep and to go out and attack it. Again, this has really been something that's been focused in treating a lot of cancers that are not otherwise responsive to these immunotherapies. This is an example from one of these agents, and you can see that it's got reasonably high response rates compared to what we see with just a checkpoint inhibitor by itself. About a third of patients had a PSA response. The next agent I wanted to mention was these CAR T cells, or chimeric antigen receptor therapies. And these are really a cool new form of treating cancers, which has really gained a lot of traction initially in lymphomas and leukemias, but it's beginning to be developed for things like prostate cancer too. Essentially what they do is they take the T cells from an individual patient through a process called leukapheresis. And then once they have these T cells in the laboratory, they genetically engineer them to express these receptors on their surface that are really highly active and able to in their ability to grab onto a cancer cell. So this sort of genetically engineered cell is now able to go out after you give it back to the patient, find the cancer cells, bind it, and kill it. And so when they look at these in prostate cancer, the data is early, but they do look promising. You're seeing, again, PSA response rates probably in about a third of patients. And overall, I think there's a lot of enthusiasm for developing these approaches. With both of these agents, though, I just should point out that there is the potential for toxicity here. And specifically, one thing we worry a lot about is something called cytokine release syndrome. This is basically a non-specific toxicity that occurs because you get sort of overactivation of the immune system. And this is characterized by fever and multi-system organ failure. And it really kind of looks similar to what you see with uncontrolled sepsis from an infection in a patient. And so this is something that can be quite serious and can even be fatal in some cases. So, you know, while these BiTE therapies and CAR T therapies are really, you know, exciting, there's the potential that it could cause these problems. And I think it's just something we need to be very cautious about in terms of how we use them. This is just some data from that BiTE trial I mentioned earlier, looking at the safety of it. And I'll just point out that as far as cytokine release syndrome is concerned, they saw that occur in 90% of patients, while only about a quarter had more serious cytokine release syndrome. And in most of the cases, they were able to manage this reasonably well. But again, it's something you need to be aware of. Likewise, with the CAR T cell data that I just showed, we also saw cytokine release syndrome with that, and about 50% or so had cytokine release syndrome with that one. Again, it was relatively low grade in most cases and able to be managed in many instances, but there's still the potential for serious toxicity. So again, word of caution. All right, final topic I want to talk about is the use of PARP inhibitors and how to sort of refine and expand their use. So I think Dr. Vuky had already discussed PARP inhibitors a little bit, but you know, just to refresh our memory, these are really only effective for a subset of patients currently in terms of how we use them in the clinic. When you think about two cells, a cancer cell and a normal cell, and you expose them to a DNA damaging therapy, if you happen to have a cancer cell that has had a mutation in its machinery that allows it to fix this DNA damage, what happens is that cancer cell can't survive this DNA damaging therapeutic. It's sort of a vulnerability that we can exploit to our advantage. Meanwhile, the normal cell has normal DNA damage repair capabilities. This is, again, something that's redundant in every cell so that we can survive, you know, things that happen in life that can hurt DNA and allow the cell to continue to live. And so it allows us to selectively kill off the cancer cell while hopefully leaving the normal cells relatively unscathed. And again, this led to the approval of olaparib, as Dr. Vuky mentioned, but I think that it's worthwhile looking at some of the data that led to that approval a little more closely. So one thing worth noting is that within the context of that big trial that led to olaparib's approval, there are a lot of different mutations that can qualify for treatment with that drug, but that study really focused on just a core set of 3 mutations, the BRCA1 and 2, CDK12, and ATM mutations. And when you look at the BRCA cohort on the left here, you see they do pretty well. The progression-free survival with olaparib in that setting is clearly better than patients who just got a hormonal drug like abiraterone or enzalutamide. Meanwhile, the ATM and CDK12 cohorts, not so much. I don't see much of a separation in those curves there, and I'm not terribly convinced that the drug works for most patients with those mutations. Looking at the sort of group who sort of excluded those more common mutations, you also don't see any clear benefit in that respect either. And so I think we need to have better ways to identify patients that are likely to respond to these drugs. I think ultimately the problem is that it's hard to tell which individual mutation will actually have a functional downstream effect on that cell's ability to fix the DNA damage that you see with drugs like olaparib. One thing that we've noted in the lab, though, is that when you actually have a cell that has impaired ability to repair DNA damage, this actually leads to sort of these scarring effects across the entire genome. The DNA across the entire fragment of DNA that you look at will have sort of these changes that are a characteristic result of having impaired DNA damage capabilities. And it's this scarring that may reflect sort of a more functional inability to fix DNA damage. And so we're interested in looking at whether or not we can detect these genomic signatures or genomic scarring as a way to identify patients that really have impaired ability to fix the DNA damage and target those cancers with drugs like PARP inhibitors. And so just point out that some work out of the Nelson lab at Fred Hutch was looking at trying to develop one of these signatures specifically for patients with prostate cancer. They call this an integrated homologous recombination deficiency signature. We call it IHRD for short because that's a lot easier to say. Essentially, it combines a lot of features of scarring that we've noted in other contexts and tries to sort of roll them into one biomarker that we can use to identify patients who might respond well to PARP inhibitors. And it performs pretty well. I would say that, as far as the BRCA mutated cancers, you see that 95% are positive, which makes sense because these tend to respond quite well to these PARP inhibitor type drugs. Conversely, patients who have tumors with ATM or CDK12 mutations, these less common ones, you don't see the IHRD score being positive in most cases, only like 11 to 15% of cases. Probably the most interesting thing to me, though, is that 18% of cases that don't have a mutation in a DNA repair gene also have IHRD positivity. So it raises the possibility there may be other cases out there that are likely to respond well to PARP inhibitors that we haven't even tried yet. So we have a trial looking to just this. Essentially, what we're doing is we're enrolling patients who've undergone genetic testing at our center. And if we see evidence that they have one of these IHRD positive cancers, they can go on this trial and get olaparib. And the goal is to really see whether or not we can see high response rates in patients who may not necessarily otherwise respond well to these drugs. But what about patients who don't have mutations in DNA repair genes? There has been interest in developing sort of combination strategies where you put drugs together that may potentially synergize to allow PARP inhibitors to work better. One approach that's been tested is the use of abiraterone, a common hormonal therapy plus PARP inhibitors. And this was developed based on the idea that these drugs like abiraterone are actually able to decrease the expression of DNA repair genes so that maybe it can sort of recapitulate what you see in the patients who do have these mutations, even in those that do not. And then also there's data that PARP as a protein is able to actually trigger androgen receptor to become active. And so, as I talked about earlier, abiraterone also targets androgen receptor. So you're kind of combining two drugs that do a similar thing. And so this is a complex figure, but essentially this was a study that was looking at just that, combining a PARP inhibitor called niraparib with abiraterone to see whether or not you could see a beneficial effect. Now, when they looked at patients that had no evidence of a DNA repair mutation, you didn't see much added benefit from combining the two. And so ultimately, the researchers involved in this study said, we didn't really see a signal here. We're not going to pursue this further. They did see that there was perhaps a marginal increase in the time to progression when you combined a PARP inhibitor with abiraterone compared to just abiraterone by itself, but it was pretty tiny. And there was added toxicity. So I think we need to sort of watch this a little closer to see whether or not it makes sense to use this combo in patients who do have mutations in DNA repair genes. A similar study, Propel, was looking at a very sort of parallel type of question, combining olaparib this time with abiraterone versus abiraterone alone. They didn't sort of decide that sort of one of the main goals was to look at the patients with mutations versus without mutations separately, and instead they lumped everyone together. And they saw, again, there was an improvement in time to progression with the combo. When they look specifically at the group that either did or did not have mutations in these homologous recombination or DNA repair genes, they see that the group that did have the mutations did probably better than those that did not. There was still a slight separation, even in those that didn't have the mutations present. However, again, this was a small difference, and ultimately there were some questions about how they went about testing for this, since it wasn't something that was sort of prospectively evaluated in the context of that trial. Again, I think one of the big issues with both of these is that these combinations do have increased toxicity. And I'll just point out that the rates of anemia, low red cells, was quite high in these trials. And patients getting the combo of olaparib plus abiraterone required blood transfusions in about 16% of the cases. And so that's pretty high. And you think about the sort of having to have patients come in for blood transfusions regularly due to a therapy. It makes you sort of pause and really want to see additional long-term data before you would decide to use this as sort of a standard of care. Last thing I wanted to briefly touch upon was we've also done some studies looking at using BAT in combination with PARP inhibitors. This was based on the idea that BAT actually is able to induce DNA damage as well. The figures on the right here show what happens to a prostate cancer cell when you treat it with BAT, and all the green dots show that the DNA is being damaged. We also know that BAT can also suppress the expression of DNA repair genes. And so kind of led to the rationale for this trial where we're combining bipolar androgen therapy with olaparib here, again, a PARP inhibitor. And what we saw here was actually the combination that worked really well. We saw PSA response rates in over 50% of patients. Likewise, radiographic responses were over 50%. And I'll just point out that the blue bars here represent patients that do not have mutations in these HR genes, and the orange bars are ones that do. And overall, we didn't see any clear difference in outcome. So it looks like this effect is beneficial in patients regardless of whether they have mutations here or not. And then likewise, looking at radiographic progression-free survival, we saw that this was quite long, over 13 months in the whole cohort. And again, no clear difference in those that did or did not have a mutation present. So what do I conclude from all this? So a lot of exciting stuff happening in the field. BAT still appears very promising, although I think that it needs to be given either in combination or used as a sensitizing agent, or maybe developing biomarkers to identify who that 25% of patients are that really respond well. Right now, checkpoint inhibitors alone don't look like they work well for prostate cancer, but there's a lot of exciting novel immunotherapies being developed. I will say that these do carry some risks, so we need to be cautious about how we use them. And then finally, PARP inhibitors are an exciting new drug. I think we need to develop better ways to identify all the patients that are likely to benefit and not necessarily use these drugs in those that won't. And I think combination therapies appear promising. I personally think we need to see more long-term data on the use of PARP inhibitors with abiraterone before I'd be ready to use it in clinic. I do have concerns about the toxicity of this combo. And again, I think that using BAT plus PARP inhibitors looks pretty promising and justifies additional study as well. So thanks. And I think if you have any questions, feel free to email me or happy to answer them in the chat.
Hello, everyone, and thank you for tuning in today. My name is Meghan.
And my name is Christine.
We are both sexual health clinicians with the Prostate Cancer Supportive Care Program. Today, we'll be presenting on how to enhance intimacy and sexual adaptation following prostate cancer treatment. We'd first like to introduce our program. Our program is currently comprised of 8 modules listed on this slide. Christine and I work within Module 2, managing the impact of prostate cancer treatment on sexual function and intimacy. In this presentation, we will talk about the different types of intimacy and the different aspects of sexuality. Then we will review the sexual consequences of prostate cancer treatment and how to navigate those changes through sexual adaptation. And lastly, we will get into how to enhance intimacy.
I'd like to introduce you to John and Martha. John is 70 years old, a loving father of 3, and has been retired since 2015. He and Martha have been married for 45 years. John was diagnosed with prostate cancer last year. This came as a surprise to him, as he always considered himself to be a healthy guy, and this was his first major diagnosis. John and his doctor decided a prostatectomy or removal of the prostate was the best treatment for his cancer. He had his surgery and recovered well with a few side effects. After his surgery, he noticed his relationship with Martha had changed. They were no longer as close as they once were. He felt ashamed that he could no longer perform as he once had before surgery. He wanted to be able to please Martha and thought, why start something I can't finish? Soon they had lost all types of intimacy in their relationship, and Martha wondered, why doesn't he feel attracted to me anymore? The couple didn't discuss their unhappiness, as they were afraid it would embarrass or hurt the other person. One day, Martha sees a flyer for a talk about intimacy and sexual adaptation, and she thinks, why not? It couldn't hurt. They attend the group session virtually and learned about all the ways they can enhance their intimacy and rebuild passion in their relationship. John and Martha overcame the challenges of prostate cancer treatment, and they continue to build a loving and intimate connection together. While their sexual relationship isn't the same as it used to be, they've developed an entirely new way of being together. John tells us that they've reignited their passion in the relationship, and they are closer now than before his diagnosis. This story is one of many scenarios couples can face when going through prostate cancer treatment. Prostate cancer treatment can create an opportunity for you for a change in your usual way of being sexual or intimate. Today, we hope to share some knowledge with you that will help empower you in your journey. We'll look at ways to enhance intimacy and navigate the sexual adaptation process, regardless of if you are in a relationship or are on your own.
Let's first take a look at what intimacy is. Intimacy is an umbrella term for that affectionate or loving personal relationship with another person. It's that closeness you feel with someone. There are multiple dimensions that make up intimacy, and it's very powerful to share with another person. First, you have your intellectual intimacy. That's a rich meeting of the minds. They're your thoughts, ideas, and your connection on values. Next, you have your experiential intimacy. That's your closeness in activities, what you do together that you enjoy. Then there's sexual intimacy, which is our practices of sexual relationships with a partner. And then you have your emotional intimacy, which is how you support each other. It's about being vulnerable and having those feelings of closeness and trust. There are many ways of being intimate with one's partner, and it's important to communicate what dimensions of intimacy are important to you and how to maintain that closeness throughout your relationship. While each bubble on the screen is equal in size, this can actually vary from person to person. That is to say, people will place different degrees of importance on different bubbles, and that is normal. Now we'll take a closer look at sexuality, as there are many components within that. Sex is what we do, and sexuality is the essence of who we are as unique individuals. It's how we express ourselves, what brings us joy and pleasure, and it encompasses all the feelings, attitudes, and behaviors that contribute to our sense of self. On the screen, you can see what we call the wheel of sexuality. It shows the diversity of our sexuality. So take a look at these words, and you can ask yourself, what influences your sexuality? What makes you feel like a sexual person? It's important to recognize where our feelings of sexuality come from and to understand that there are many components.
You probably heard of or have already experienced that treatment for prostate cancer can affect your sexual functioning. On top of that, everything listed here on the screen can also be consequences of treatment, and they can change your usual pattern of being sexual and feeling close with your partner. When your usual pattern of being sexual has changed, this requires adaptation. The process of sexual adaptation can be challenging. It's important to reflect on these 4 principles to help you move forward. Having acceptance in how things may have changed in your functioning or in your relationship, being flexible and trying new things, and then remembering to have patience and persistence. How many people have learned how to ride a bike the very first time they sat on one? I'm sure most of us have fallen off and gotten back on. It takes patience and persistence to learn and adjust to something new, just like anything in life.
So today we will share a few strategies that you can put in your intimacy toolbox to restart that romantic and loving connection with your partner. And if you're single, just know that all of these apply to you in focusing on your own sexual health as well. A lot of the time, couples can be focused on erectile dysfunction treatment as they want to engage in intercourse again. Erectile dysfunction treatments can include PDE5 inhibitors, otherwise known as the pills, intraurethral suppositories, vacuum erection devices, or intracavernosal injections, otherwise known as penile injections. There is nothing wrong with wanting this, yet it's important to remember that there are many ways of enhancing intimacy in your relationship. Expanding your focus will give you more opportunities to find what works for you and your partner. Communication is the best way to enhance intimacy and increase sexual satisfaction in your relationship. Here are some tips for talking to your partner about sexual problems. We often think that we know someone so well that we can read their mind, but this isn't true and research has proven this. It's important not to assume how your partner feels, especially when it comes to sexual dysfunction. Remember in the beginning story when John wouldn't talk to Martha because he was ashamed of his sexual dysfunction, and Martha wouldn't talk to John because she felt he wasn't attracted to her anymore? It's best to communicate and to always ensure that you're on the same page. So how do you do this? Think about what is important to you and your partner. Set aside some time together to have a private conversation where you can discuss your thoughts and how to make changes. Make sure you ask your partner how they're feeling and acknowledge their feelings. Some couples find it easier to write a note or a letter to their partner to discuss their needs, and sometimes it can be helpful to see a relationship counselor or sex therapist together. They can be really helpful in opening the conversation and helping you to enhance intimacy.
Now, coming back to our intimacy toolbox, let's take a closer look at an activity called Sensate Focus. Sensate Focus is an activity for exploring touch and accessing different feelings of pleasure. It was developed as a way to help couples learn about themselves and each other and to move towards a more fulfilling, intimate relationship. The aim of Sensate Focus is to build trust and intimacy within your relationship, helping you to give and receive pleasure. So let's look at this in more detail. There are 3 different phases of Sensate Focus, and we'll look at each of these stages. The first one is non-genital Sensate Focus. This is touching, stroking, or kissing anywhere on the body except the breast and genital areas. If you are the giver, start with your partner's face and work from head to toe. Take your time and explore every area of your loved one's body. You can explore different types of touch, such as rubbing, squeezing, or tickling if your partner allows it. The goal is to experience the sensation of touching, and it's not meant to sexually arouse your partner or lead to any certain destination like orgasm. And even if your loved one gets aroused, do not try to have an orgasm, as this is meant to be an intimacy building activity. After 15 or 30 minutes or longer, if you like, switch roles. So now instead of being the giver of touch, you'll be the receiver. You will explore phases 1 for as long as you're comfortable with. And after a few times trying that, you can move into phase 2. Phase 2 is more touching of the breast and genital areas without attempting intercourse. Again, this isn't meant to lead to a specific destination. It's meant to access all those areas of pleasure and exploring your partner's body. And at the last session, you can be penetrated Sensate Focus. During this stage, you will engage in mutual touching, beginning with stage 1, moving to stage 2, and then if you're comfortable, getting into position as if you are going to have intercourse. Move your body so that your partner's genitals can rub against yours. After 1 or 2 sessions, you can progress to full intercourse, or you can just continue with touching or oral sex that leads to orgasm. It's helpful to have the lubricant nearby so you don't need to interrupt the session to locate anything. Sensate Focus can be a great way of enhancing intimacy, especially if it's been a while since you and your partner have engaged in any of those activities. It's a nice build up to accessing pleasure and exploring your partner's body. Here are some tips for engaging in Sensate Focus. Try not to talk during the activity. Use your hands to guide your partner. Choose a time and place acceptable for both of you where you won't be disturbed, and make the surroundings as pleasant as possible. Choosing music, lighting the area, putting on a nice scent, whatever is enjoyable to you. Try to enjoy the journey rather than aiming towards a specific destination. Don't rush anything. Oftentimes, the slower you take it, the more you'll get out of it. Make sure that you're respecting boundaries and only move from one phase to the next if both parties agree.
Now we'll take a closer look at creating a passion plan, which is another way of enhancing intimacy, and a lot of people like to incorporate the Sensate Focus activity into their passion plan. Now, what is a passion plan? Dr. Cheryl Fraser designed the passion plan to help couples recharge their romantic and sexual life. A lot of the time, couples tell me that they think sex should be completely spontaneous without ever talking about it. Their partner just gives them a look, or they should just know when you're in the mood. Sometimes that works, yet a lot of the time it doesn't. And especially after prostate cancer treatment, that pattern of how you communicate or engage sexually with your partner can change. Planning passion into your life can make your sex life better, enhancing that closeness you feel together, and it can strengthen your relationship. Here's a quick look at an example of a passion plan. You and your partner set goals for creating more passion in your relationship, and you can do this anywhere. You can write it on a piece of paper and put it next to the bed or on the fridge, wherever you're comfortable. You can plan daily, weekly, monthly, and annual goals to enhance your intimacy. And it can be anything that makes you feel closer. If you always wanted to take dancing lessons together, try a new sexual activity, or just increase the amount of time you're spending together, this can be a great opportunity to sit down with your partner and commit to being passionate together. It's never too late to show your partner that you care about increasing that connection. We've included a few examples here. Cuddling before bed and showing appreciation daily. Weekly, you can have a date night or massage night. You can incorporate sensate focus into your weekly plan. And then some other activities can be for working on your relationship, like attending counseling or going to a workshop together. There are all sorts of ideas out there, so feel free to explore.
So now we'll take a look at ways to enhance libido, as this is a common concern after having prostate cancer treatment, especially if you're on hormone therapy. A lot of patients will tell us that they've started a passion plan but are having a hard time following it because they don't have the same sexual drive as before. Sometimes treatment or age or other life challenges can change your sex drive, and that can make it challenging to be sexual with yourself or with your partner. When that drive is low, or if you're having changes with sexual functioning, initiating sexual activities can be so overwhelming that you don't even want to start them. Remember John in the initial story who had some issues with sexual functioning, specifically erectile dysfunction. He thought, why start something I can't finish? Remember, appetite comes while we eat. It's an idea of starting intimate activities without pressure to arrive at a specific destination, such as intercourse or orgasm. Most of us have experienced a lack of appetite where the idea of being expected to eat a large meal can be pretty overwhelming. So imagine you come home and your partner has made your favorite meal. For now, we're going to use my favorite meal, which is a delicious, heartwarming stew. So you see this large bowl of stew and you think, oh, I'm not really feeling hungry yet, but I'll try a few bites. The more you eat, somewhere you think, wow, this tastes really good. I'm going to keep eating this, and soon you have finished the whole bowl and you're having dessert. When your sex drive is low or you have changes in your sexual functioning, the thought of initiating sexual intimacy can be overwhelming. It's about starting slow and being open to trying new ways of intimacy together that could be pleasurable and bring you closer. So the next time your partner mentions having a sensate focus night or trying a new sexual aid, such as a vibrator, try taking a few bites and see where your sexual appetite goes. You can still access joy and pleasure in being sexual with a low libido. Another way to increase your libido or sex drive is called simmering. Simmering is a process of nurturing a conscious thought around something that is sexually appealing to increase your sex drive, so that when you go to engage in sexual activities, your mind will be turned on, which can increase arousal. So let's talk more about this. The thought can be a previous sexual encounter. It can be from a book, a movie, or a fantasy. Throughout the day, reintroduce that thought back into your mind, like simmering that thought. Then when you have that sexual encounter, you'll have that sexual thought build up in your mind. Many couples find it pleasurable to send sexual text messages or notes throughout the day. This can be a great way to build that sexual tension. Watching TV or reading erotica can sometimes help to find out what works best for you, as there are many options out there to stimulate those sexual thoughts.
Next, we'll take a look at cognitive behavioral therapy and mindfulness. Both of these practices can help improve intimacy as well as feelings of masculinity and sexuality. They can also help relieve stress and improve depression. Cognitive behavioral therapy, or CBT for short, is about identifying and challenging negative thoughts. A distorted or unhealthy thought might look like catastrophizing, focusing on the negative and ignoring the positive, polarized thinking, which is all or nothing thinking, jumping to conclusions, or overgeneralization, which is assuming a rule from one experience. There are many other types of distorted thinking, and recognizing them is the first step. For CBT, we recommend working on one guide or worksheet per week and to revisit this 2 to 3 times a week. In the long term, you can reach for the worksheets when you are finding yourself having reoccurring stressful thoughts or thoughts that you can no longer manage. Here are some CBT tools you can try. First, we have journaling. This is the act of self-reflection and identifying thought patterns. This will help you gather information about the negative thoughts, such as the source, the timing, the intensity, and how you reacted. Next is unraveling cognitive distortions. This is the main goal of CBT. This involves challenging harmful automatic thoughts, such as the types of distorted thoughts mentioned earlier. Then we have cognitive restructuring. Once you've identified the negative thoughts, you can explore why you came to believe them. If this belief is destructive or harmful, you can begin to challenge it. An example is believing that having a certain job makes you a respectable person. But if you lose that job, you may start to feel bad about yourself. Instead of accepting the faulty belief that causes you to feel bad about yourself, you would take the opportunity to reevaluate what really makes a person respectable. This may not be a belief you had explicitly considered before. Next, we have progressive muscle relaxation. This technique is similar to something you may practice with mindfulness. With progressive muscle relaxation, you relax one muscle group at a time until your entire body is in a state of relaxation. You can use an audio guide, a YouTube video, or simply guide yourself. Lastly, we have relaxed breathing. For this technique, you can also choose to use an audio guide or video guide. Relaxed breathing is about relaxing and bringing regularity into your breathing. This can be helpful for managing anxiety, depression, or stress. There are many other tools available, and they can be easily found online. You can check out websites such as positivepsychology.com or therapistaid.com for ideas. Here is an example of a CBT worksheet. By following the arrows, the worksheet asks you to think about: what was the triggering event? What is the problem or distorted thought? How are you handling or coping with this thought? And how can you reframe your thinking to respond differently next time? Hopefully you can see how the tools we just reviewed can help you work through your thoughts and feelings so that you can fill out the boxes in this worksheet. To recap, the goal of CBT is to challenge negative thoughts and to reduce the power they have over our behavior and how we feel, which ultimately impacts our quality of life.
Mindfulness is derived from a Buddhist practice and is based on meditation techniques. The practice focuses on your ability to be aware of your thoughts, emotions, and physical sensations in a moment without any judgment or criticism. And as mentioned before, mindfulness can help reduce stress and anxiety. So how do you practice mindfulness? Mindfulness is a form of meditation, so you can sit in a quiet, comfortable space and focus on concentrating on your breathing. Pick your favorite place and take a mindful walk. Engage your senses, notice the sights, the smells, the sensations, and the feel of the world as you move through it. There are also quite a few apps out there on cell phones that contain guided mindful sessions. Smiling Mind is a free one that can explore, or simply searching guided meditation session on the computer can help bring up lots of websites. A lot of adults like coloring. It's a great way of turning off those thoughts and feelings and just focusing on one thing. Having a mindful shower or bath can sometimes help too. The primary objective is to bring your attention to experiences, thoughts, and feelings that occur in the present moment without judgment. So now that we've reviewed everything, we're going to focus on some key points to take home from this presentation. It's important to communicate, have more open conversations with your partner, listen to what they say, try not to interrupt, and practice active listening.
Schedule some time together with your partner for just the two of you. Intimacy is whatever you do together when you're alone. Try writing a passion plan to have more of that intimate time together.
Tell your partner that you love them and appreciate them every day. Even something as simple as a text message or a little note or a quick reminder can go a long way.
And then enhancing your intimacy with more physical contact. So having that 30-second hug every day, cuddling, kissing, hand-holding, anything that makes you and your partner feel good.
And remembering that your partner is there to support you. Don't be afraid to let them know how you're feeling, as chances are they may need your help as well. Everyone needs help sometimes, and that's okay. Meghan and I want to thank you, and we hope that you now have some extra tools in your intimacy toolkit.
Hello, my name is Andrea Holmes. I'm a registered dietitian at the Prostate Cancer Supportive Care Program. I've worked in the area of oncology and nutrition for about 20 years. Today, I'd like to start by saying thank you to the organizers of this conference for inviting me to speak and for recognizing that nutrition is an integral component of optimizing longevity and vitality for people with prostate cancer. In the 25-30 minutes we have together today, I'm going to touch on a few of the questions I'm commonly asked by my clients. A cancer diagnosis for you and your family members changes your world. A lot of questions come up, and it often results in going down a rabbit hole of research, often leading to more questions than answers sometimes. Things can get confusing. When it comes to nutrition, you will find information that is conflicting. Why? First, nutrition research, like all realms of science, is evolving. There can be a lot of old, outdated information that you come across. Most sources aren't dated. So you really can't tell if that information is old or current. Second, the nature of the scientific process is it starts with an observation, which leads to laboratory research in test tubes and cells and animal research. And that type of research is really essential in helping us understand things. But what happens under the microscope doesn't always translate directly into what happens in the human body. Sometimes online, you cannot tell what type of research is being quoted. Are they speaking about something in a rodent, or are they speaking about something in a human? We really can't make recommendations on changing the diet based on what we see in a test tube. And third, sadly, good quality human research studies are hard to undertake. We don't have a lot of them. The ones that we have often involve small groups of people over short periods of time, or they look at large groups of people, but they really just observe and ask questions maybe once a year about what they're eating. This means that one type of study or research method is never going to be enough to give us convincing evidence on how to change our diet. So to make sense of this information, we need to assess it in its totality and as it evolves. And that's the perspective I'm bringing today to this presentation, so I can share what I've been observing over the past couple decades. We aren't going to be able to cover all your questions today, so I'm also going to be sharing with you credible sources where you can go for answers to your questions. So question number one, very common to wonder if any specific food can help slow down the growth of prostate cancer or the chance of it returning. Now, while many individual studies or individual foods have been studied, and this is an area of ongoing research, what we're learning really is that it isn't any single food, but your overall diet that has the greatest impact on your health. And we're going to cover more about that later. I'm going to, though, touch on some of the foods that have been researched that might be beneficial for people with prostate cancer. First is lycopene-rich foods. So lycopene is an antioxidant nutrient found in high amounts in tomato, as well as other red fruits such as watermelon or red grapefruit. A number of studies have linked cooked tomato and tomato-based foods with reducing the risk of developing prostate cancer. Only a couple of studies have looked at the impact of lycopene after diagnosis. So some of that research is promising, but not all studies have shown a link. So that means we still need more research to really understand the effects of lycopene after diagnosis. Even so, I think we know that these types of foods are generally healthy, and we do encourage you to eat them often. We cannot give you a specific portion or recommendation of how much or how frequently to have them, but I would say include lycopene-rich foods such as cooked tomatoes, along with a variety of other fruits and vegetables in your diet. We don't recommend, though, taking a lycopene supplement. Current research tells us that it's eating food rather than taking supplements that is the best way to get the beneficial anti-cancer compounds from our fruits and vegetables. So when we get nutrients from food, we don't get that single isolated compound. We get a mixture of other vitamins, minerals, and other plant compounds that interact in special ways to support your best health. Another vegetable of interest really is a family of vegetables, and this is the cruciferous vegetable family. Cruciferous vegetables include broccoli, as well as many others, such as bok choy, cabbage, Brussels sprouts, collard greens, kale, turnips, radish, arugula. There's many, many more consumed around the world. Broccoli is probably one of the most studied and definitely promoted as part of a healthy diet, and really rightfully so. Intake of this family of vegetables is linked with reduced risk of heart disease and stroke, and lowered risk of developing aggressive prostate cancer. Now, you can sometimes recognize these vegetables by their very distinctive kind of sulfur smell, especially when overcooked, and a bit of a bitter kind of spicy taste. So those characteristics are signaling the breakdown of a sulfur-containing phytochemical called glucosinolates. And it's this compound that is then further broken down through the process of digestion into compounds that have shown anti-cancer effects. We, again, unfortunately have only limited research for this vegetable, and while not yet proven to slow prostate cancer progression, there is one study in people with non-metastatic prostate cancer who consumed half a cup of cruciferous vegetable a day, and they had substantially lower risk of recurrence compared to people who ate none. So again, we can't really tell you how much or how often to eat these vegetables, but we would encourage frequently. Soy is another food that many people ask about. Is eating soy helpful? And it has been an area of interest for decades. Initial excitement in soy with the observation of a lower risk of prostate cancer in Asian countries, where we know that soy traditionally is a staple in the diet. And this led to quite a bit of research in soy. In the 1990s, it was recognized that soy contains a number of bioactive compounds that have anti-cancer activity. One of the key compounds is called isoflavones. Is called isoflavones, and of which soy is the most concentrated source in the human diet. So isoflavones are similar in structure to human estrogen, and in laboratory studies, they have been shown to inhibit prostate cancer cell growth. However, the research in humans and people after diagnosis is still very weak, and eating soy foods hasn't been shown to have a significant benefit to reduce the progression of prostate cancer. So we don't have compelling research to consider soy a must-have in your diet, but it is a healthy food and probably imparts some health benefits, particularly when used as a replacement for processed meats, high-fat meats, and high-fat dairy. All right, so question number 2. So if we're thinking that we can't slow the progression specifically with any single foods, are there any foods though that we would want to avoid because they might encourage prostate cancer growth or the chance of it returning? So are there any foods I shouldn't eat? The research here also, we don't have a robust amount of research to go on, but there are a few studies suggesting that high intakes of animal fats, such as that found in processed meats, red meats, which includes beef, pork, lamb, and goat, as well as whole fat dairy milk products, increases the risk of having a shorter life after prostate cancer diagnosis. This is likely related to the harmful effects of the type of fat found in these foods for heart health. It's also well known that eating too much red meat and processed meats can increase the risk for colorectal cancer. And so for this reason, we do recommend limiting red meats. And if you are to eat red meat, to choose lean cuts, not more than 500 grams or 18 ounces in a week, and to avoid processed meats. So processed meats being your bacon, ham, deli meats, hot dogs. So those are best avoided or eaten in very little quantity. And if you consume dairy products, make sure they are lower fat options, such as 2% non-fat milks and yogurts. Or consider a mixture of dairy in your diet and non-dairy alternatives, such as soy, nut, or oat beverage. Now, high intakes of red meat, processed meat, and high-fat dairy, along with regularly eating highly processed foods, such as refined grain products, foods high in sugar, these are hallmarks of a Western diet. And there is research suggesting that a Western diet is linked to higher risk of progression as compared to eating a whole food plant-based diet. So we're going to touch a little bit more on that in our next question. What should I eat? So what should I eat? Now we're thinking more than any single food. We think that it's your overall diet that makes a difference. And that's really what matters when we're thinking about your best health after diagnosis. And when it comes to the question of best diet as well, it's really important to recognize that there isn't one diet. It really does need to be tailored to each individual. Each person has unique nutrition needs and goals. So some people might be aiming to regain strength. Other people have other health conditions that they have to consider, such as diabetes. Some people are in active treatment. Some people are being carefully monitored. And of course, we have cultural and personal preferences. All of those things are going to be making a difference when we consider the best diet for a person. If you have opportunity to have a one-on-one consultation with a dietitian, I think there's a lot of advantages to having that moment to review how you eat, how that is connected to your family, and seeing if you're already on track or if there's ways that you can optimize. So I also would strongly encourage, and not even consider it optional, but if you are having some treatments right now that are affecting your weight, your appetite, your bowels, and you're struggling to know what to eat to feel well, then it is really paramount that you work with a dietitian, because managing those symptoms is priority one to having your best health. Now, for those of you who have an appetite, no diet restrictions, and are generally well-nourished, the foundation of healthy eating after diagnosis is a whole food plant-based diet. This is a diet that is rich in fruits and vegetables, whole grains, and legumes in their most natural state, and is lower in those common hallmarks of the Western diet, the processed foods, sugary drinks, sugary foods, and red and processed meats. I also want to say that the more we eat this way, the better. But healthy eating is not about perfection. Not every meal you eat needs to be nutritious in order for you to be healthy. And it is really important that you enjoy your food and enjoy eating. And that we can let go of fear around food or the hesitation to eat some foods or label foods as bad. Again, we know it isn't any single food that we eat or even a single meal that is going to impact our physical health. It is how we eat overall and how we eat most of the time that makes a difference. So eating well most of the time is really about your overall health, helping to prevent and manage other chronic conditions such as diabetes and heart disease. And this is especially important when we recognize that heart disease is the #1 competing cause of death for people with prostate cancer. So thinking about having a heart-healthy diet is very important. So at this time, some of you might already be eating a whole food plant-based diet. Some of you might eat that way occasionally, and some people not yet at all. We're all starting at a different place. When you are ready, choose what you can do when you can. Start. Again, if you're going through treatment, still recovering, you might want to consider just consulting with your dietitian or doctor before launching into a lot of dietary change. One of the most powerful tools you can use to get started with this whole food plant-based diet is your plate. And this image is from Canada's Food Guide, designed for the general public, but it is a really great guide for cancer protective eating. So what we see is a plate filled half with vegetables and fruit. So this is your salads, your carrots, your broccoli, tomatoes, greens. It could be whole fruit, fruit salad, frozen berries. You just want to aim for that half a plate. Look for a lot of different color and variety. A quarter of your plate is for your whole grains, such as quinoa, brown rice, farro, and you can replace that grain with starchy vegetables if you choose, like potato, sweet potato, or corn. And then we have the other quarter of our plate for our protein-rich foods. So the key here is the balance and the proportions. And I really want to take a little extra time to discuss the importance of protein. I often see protein missing in the diet when people transition away from that heavy meat base to one that's more plant-based. So when you remove animal protein from your diet, it is very critical to replace it with a plant protein instead. Protein is an essential nutrient. Everyone needs it, and it's especially important as we age or when faced with medical conditions. You probably know that protein is important for building and maintaining strong muscles, but it is also involved in healing, bone building, and for a healthy immune system, and many other bodily functions. So the tremendous importance of protein is even more evident when you combine all the roles protein plays in the body with the fact that when you're undergoing cancer treatment, most people have increased protein needs. So how much protein do you need? For an average adult, it's calculated as 0.8 grams of protein for every kilogram of body weight. So for someone who has a weight of 154 pounds or 70 kilograms, the need is about 56 grams of protein daily. Now, if you're having cancer treatment, including androgen deprivation therapy or ADT, your protein needs are higher, typically in the range of 1 to 1.3 grams per kilo of body weight. So now that same person needs closer to 70 to 90 grams of protein a day. So 14 to 35 grams more each day. Now, how can you get the protein you need? First, you need to know which foods give you protein. And protein is found in both animal and plant-based sources. Animal sources include your fish, chicken, poultry, eggs, meats, milk, dairy products. And plant-based sources include your beans, kidney beans, black beans, dried peas, chickpeas, lentils, soy foods, as well as tofu, edamame, for example, nuts and seeds, and nut and seed butters. We do get small amounts of protein from whole grains, but very small, 2 to 4 grams per serving, and about 1 gram per serving for fruits and vegetables. So they still can contribute some, but they aren't really rich sources. So eating a plant-based protein, eating plant-based protein often is encouraged because they do offer those cancer-fighting compounds. They're great for fiber, which is good for your digestive system, for heart health, and lowering risk of colon cancer. But we also need to recognize that you need enough appetite to eat sufficient portions of plant proteins to meet your needs. So this is something that we need to balance during cancer treatment if we are having lower appetite. So we come back to our plate, right? So it is important to consistently fill that quarter of your plate with protein foods so that you can meet your daily protein requirements. And to optimize your protein intake, you can include protein-rich snacks such as nuts and seeds. You could add protein powders to oatmeal or soups or a protein shake. You can sprinkle nuts and seeds on salads or cereals. There's a variety of ways we can optimize your protein intake if you're finding it difficult to get enough just with a quarter plate. So I just want you to think about what you ate yesterday. Just pause for a minute and think about that. Did you include protein foods with all your meals? And because I feel like this is such an important area, I'm going to leave you with some homework today. Write down everything you eat for 1 or 2 days and go back to that list of the protein foods that I shared or online resources, food labels, to estimate how much protein you actually get in the day. If it looks like you aren't getting enough, then I could go back to those meals. Could we increase your protein portion a bit? Can you add those protein snacks? And if you're having a struggle to get the protein, this is another important time to seek some one-on-one help. So we're just coming to near the end of the presentation. I want to share a few credible resources where you can find further information when you need it. So these resources are going to be reliable, accurate, current, and evidence-based. First is the National Cancer Institute, and an excellent American resource, great for Canadians too. They provide up-to-date, reliable recommendations. And I want to direct you to one area they have, and it's a comprehensive summary of the research on a wide range of supplements from like calcium to green tea, vitamin D. And you can find this by going to cancer.gov and search prostate and nutrition. That will come up for you. The next is the American Institute for Cancer Research. Fabulous recipes. They can sign up to have them emailed to you. They also have a really interesting library of foods that fight cancer that summarizes the research of a range of different foods and their impact on cancer. They have a great blog where they make comments on topical studies that come up. And then we have the Prostate Cancer Supportive Care Program. So this is our website. And you can get to our nutrition information by clicking on the little alarm clock icon for the forming healthy dietary habits. And you will also find an in-depth recording of our nutrition presentation and links to handouts on healthy eating, nutrition advice, and further links available under the resource section, calcium counters, protein content, heart healthy eating, and vegan diets. And then we have the BC Cancer, an extensive resource with, there's a great frequently asked question document, as well as tips on managing eating difficulties that you might experience. And then finally, this is for BC residents. You can speak with a registered dietitian at HealthLink BC. So no referral required for this, and you just dial the number 811, ask to talk with a dietitian. If you're outside of the province, you can always access great information through their website. So thank you so much for attending today's nutrition presentation. I hope it's helped bring a bit of clarity as you proceed along the journey of eating for your best health. Thank you.